And hello, everyone, and welcome to PerfWeb 100, Day 2. I'm your humble host, Joe Basha, and to my right is my new associate PerfWeb permanent member, Dr. Samir Patel.
Yeah, you called me Quran yesterday.
I know. Well, Patel, Quran, it kind of goes together.
Does it? No, it's not.
Yeah.
We're Hindus.
Samir, it doesn't. I don't know the difference. Hell, I can't tell the difference.
It's all
That's
good.
all right.
It's all good, Joe.
That's all right. But I got
I'll
you right.
excuse
I
it.
got you right today.
You did.
Yeah.
Thank you very much for that.
You're right. Absolutely. and I'll tell y'all that Samir is having himself a really exciting time.
I am.
He's gotten to do everything from regular hearts and valves and all that stuff to plenty of ECMO and now NRP, and we're going to be doing
stuff, by the way. NRP.
That is. Well, we're going to be doing a whole program on NRP with several lectures on that. I think that's the next up and coming thing, in perfusion. I remember, and please forgive me. I'm going to be doing some time wasting here. I hope everybody will forgive me. And I forgot to go on the YouTubes and tell everybody hello. Oh man, I'm sorry. I'm working on it. But anyway, let me do the opening remarks real quick. But I want to tell you, I think that's the next thing in perfusion. But 40 years ago, I was told, you perfusionists, you're not going to be around in 10 years.
That's what they say every 10 years. They're saying the same thing now. They're like,
Yeah.
oh, it's going to get automated.
Right.
AI.
Yeah.
That's bullshit.
Right.
Like,
And now here we
I wanna
are.
see AI pump a
Now
case.
here we are adding NRP in the whole thing,
Right.
because, that's what you got to do. It's amazing. Okay, so I'm getting on there. Okay. Welcome. You want to reach out to us, which I just would really appreciate it if you would. It'd be helpful. Is view event. I'm trying to get on it. I'm trying to get on this. Hey, Magic, while I do this, can you just help me, please? Because I'm sitting here struggling, and I can't get it on the YouTube. If you could help me, thanks. Okay, contact at perfusioneducation.com. Our call-in number, that's next, 832-239-5338.
No,
So
5358.
5358, I'm sorry.
You're okay.
832-239-5358. And then our scrolling chyron that you see there at the bottom. Is that what that's called? Yeah. Okay. But anyway, that scroll bar that you see right there, it's everything that you need. There's our phone number over here. It's somewhere over there. It's somewhere over here. I can't do it because it gets in the way of the camera. That's pretty funny. But anyway, and then our MediWeb app, we talked about it yesterday. Go on, get the app. The more people that get on the app, the better off it is for me, obviously. And I'm trying to sell 1 million of them, and we only have 999,999 to go because I bought it, one. PerfWeb podcast, go to your favorite podcast streaming platform and type in PerfWeb podcast series or just PerfWeb, and we will come up and you can listen to all of our programs on the podcast, and you can listen to this program while you're driving in the car, actually. There's most of the information. Slides are important, but really this isn't about slides. This is about imparting knowledge with actual words, that's probably helpful. I think that helps some. At least I do. I don't know what you think.
People pay for words.
Slides are important, as a guide.
It is.
But you can't just depend on just nothing but slides. You got to be able to talk, right? I think.
People like to hear voice too. I like to think slides. I was telling you today on the way here. You know, like reading and this and that. I can't stand it.
Yeah.
Given I'm super educated, but still I just can't sit down with a book or read slides. They would make me upset. But if I have a guide that's talking me through the slides, I can do that.
Yes.
Like that I can do for hours upon hours.
Yes. Yeah, that's almost fun.
Yeah, that's
when you're
fun.
actually getting it.
Right.
But, anyway, I don't know about hours and hours.
I have to.
There's only a few things in life that I know of that I could do hours and hours, and that isn't one of them. So with that said, we're going to jump right in. So maybe we could get done and actually finish even a little early if possible. I'm going to turn this over to Dr. Samir Patel. And he's not only Dr. Samir Patel, but he's going to be pretty soon extraordinary CCP. So you get to be Samir Patel, MD, CCP, or CCP, MD.
Correct.
CCP, yeah.
The
The higher degree goes last.
Yeah, exactly.
That's right. CCP,
Yep.
MD. Very good. All right. Well, it's been a pleasure introducing you again to our audience for the second time. Remember, call in, phone lines open. Tomorrow is going to be all about arguing. I'm going to try to have some more folks here that have different viewpoints than I do, so that I can humiliate them on camera.
Yeah. So
You're up.
thank you. Well, I'll at the end of this, discussion, I'll provide my email address. You can either email the email Joe provided, or you can email me directly
Yeah, they
if
can
you have any
email.
questions.
Well, our email address, contact, will get to you.
That will get to me.
If they send that,
Right.
it will get directly
There
to
you go. So we have many avenues.
But you can use your Samir Patel at HET.us. That's fine.
Yeah.
Oh, which reminds me,
What's up?
I got to tell y'all something. As you know, we're also, of course, I run HET, and
He does.
Samir is our, one of our newest members,
He's
but
my
certainly
boss.
one of our greatest members. But we just did our first case at our brand new account hospital at Houston Methodist Cypress campus. It was great.
It's a fancy hospital.
The place is incredible, and we were very, very happy to have participated in that case today. It is going to be a huge hospital with a lot of services being provided in that sector.
They have
of
AI,
Houston that
right?
is growing.
Like, or
Yeah, it's
something
all
like
the whole
that?
hospital is AI.
Has AI.
The whole hospital
That's
is AI.
just crazy. I didn't even know you could do that to a hospital.
It is amazing. It is amazing.
That's
And they've done everything. I mean, the hospital's really kind of thought of everything, including, like, how when you order food up in the unit, let's say you're watching ECMOs and you decide you're going to buy food for everybody, sandwiches for everybody, whatever, pizza, whatever you're going to do. Instead of them having to bring it up to the unit, they have compartments downstairs that they get put in and locked, and then you go down at whatever is convenient for you, open it up, the locker, and you take out your deliveries. So it's pretty impressive at what they've done with that hospital.
Leading medicine. That's their slogan, right?
That's true. That's true. But I think they're leading about everything, really,
They
when you
really
think about it. Okay, forgive me. I am so
That's
sorry.
okay.
Back to
All right.
Dr. Patel. Thank
So
you.
yeah. So what are we going to talk about today?
And when you get to that graph, okay, he asked me a question yesterday. I said,
Yeah.
no, I don't know what it is. He got so excited.
I get to teach
Tell me,
Joe
so what was
something.
it?
Darrow-Yannet diagram.
Darrow-Yannet
So
diagram.
we'll get to it around in the middle. I'll spend a considerable amount of time on that. I feel it's important. As a medical student, it gets drilled into you. They spend almost a week to a week and a half teaching you this.
Just on this one concept.
Just on this one concept. It's drilled into you, and if you understand it, it makes understanding fluid movement easy. It's taught on a grand scale. It's very generalized. I'll go over it with you guys. We don't break down the compartments into more than just ECF, the extracellular fluid, ICF. It's just talks about that. We don't talk about too many. It's not so in depth. It's all conceptual. But I promise you guys, if you get this concept, it is going to be hard for you not to understand when fluid will go where. And again, as I touched on yesterday, it's important in what we do. We are the controllers of fluid dynamics during the pump run. It's down to when we put albumin in our prime. So even before we go on, we're already addressing stuff like this. We're addressing it from the beginning till the end. It is what we do, and that's that. So let's get started, all right? And that Darrow-Yannet, I promise, it's exciting stuff. So yeah, welcome everyone. If you came here hoping to learn the glamorous side of medicine, well, you're about to be surprised, because fluids, right? Like I said, they're drama, Every major clinical story has a fluid subplot, Whether it's a crash in the OR or a marathon ICU stay on ECMO or whatever, there's always fluids always involved in one shape or form or another. So as perfusionists, like I told you guys, you orchestrate blood flow, pressure, volume during most of the vulnerable moments of a patient's life, You don't just carry out fluid orders, you influence them, This is what today is about, knowing the why behind the bag of saline, the bolus, the diuretic that they give, or they ask you to give, or like the ultrafiltration, which Joe's going to touch on after me. These all are interconnected, and that's why we decided to have Joe do ultrafiltration today, following mine. So, as I start out all of my lectures, any discussion I have, I always like to have objectives. That way you kind of have a roadmap of where we're going to. It's a busy 2 hours, this fluid talk. I'm just going to touch on it briefly, which is crazy. Again, you can spend a lot of time talking about fluids. Way more than 2 hours. I told you in medical school, they can spend months on just talking about stuff like this. I promise you, it's 2 hours, but it'll be worth it, First, what we're going to do is we're going to demystify the fluid compartments, where the water lives, why it refuses to stay, and where we put it. Why won't it just stay where we put it? Next, we're going to explore fluid shifts. What makes them happy, how to spot them, how to prevent a well-intentioned bolus from becoming a pulmonary edema, Then we're going to get into monitoring like CVP, SVV, PPV, echo, things like that. You'll learn about these as I go on. We don't do too much of this, but it can happen in the OR. CVP, obviously, we do. But a lot of this stuff can happen in the OR at bedside. Well, not at bedside, sorry, right there at the OR table. They'll pull an echo out sometimes, and they'll just start checking with the TEE. They'll use ultrasound, all kinds of stuff. So then we're going to wrap up with clinical scenarios. I'll actually throw a few clinical scenarios into the middle. It's just, I like to cover some of it before we get to the Darrow Yannet. Just kind of like an introduction into things. So, all right. So think of the human body like a giant aquarium, with different tanks, all right? You have the intracellular fluid. That's like a private pool. That doesn't really have any other compartments other than it. That's exactly as the name states, intracellular. That's the fluid inside the cells. Holds about 2/3 of the body water, okay? Then you got the extracellular fluid. That's like the shared spa. That one gets broken down further. You got the plasma, you got the interstitial fluid. When we give IV fluids, keep in mind that they mostly go into the plasma. But if it's a crystalloid, it can quickly leak into the interstitial space. So if you're given a liter like of normal saline or anything, if it's a crystalloid base, remember that it's going to move around. Like for saline, for instance, only about 250 mLs actually stays in the vasculature. So the rest, what does it do? It's off doing squishy things, like swelling tissues, lungs, eyelids, legs, just goes around. As perfusionists, you need to know that just because you gave a liter doesn't mean that you fixed the pressure. It's where the fluid goes, not how much you give, that counts. You know what I mean? So, Starling forces. This is a subject that not a lot of perfusionists like to talk about. Not just perfusionists, med school too. We used to cringe. Our face went. When he's Starling forces, all this stuff, he's just like, oh man, not this. Well, it's not that complicated. I'm going to keep it really simple, okay? Yes, it can get complicated. Let me reiterate, but I'm going to keep it simple. Hydrostatic pressure, right? What is that? That's the pressure that wants to kick the fluid out of the capillary, okay? Oncotic pressure, mostly albumin. Albumin is our main protein. It's the one that exerts the most oncotic pressure. What does that do? It wants to keep it in, okay? Now, I could go more in depth. We could talk about all the different ones, but for the purpose of our discussion today, that's more than enough. Let's just leave it at those two. Again, this subject, you can get in depth.
And would you forgive me if I just made the comment that it's not called it? We call it colloid oncotic pressure,
osmotic pressure.
But if it's oncotic, it's the colloid is inferred. You're saying colloid pressure.
Right.
So oncotic is colloidal.
Is colloidal. Right. Correct. Good point. Again, keeping it simple here, Joe. Keeping it simple.
These are very important things people
They
need
are.
to know.
They are important. So, if under normal conditions, you want to keep the party balanced, but in surgery, inflammation, things can get crazy, especially because we hemodilute, we drive these pressures through the ringer for the most part. Hydrostatic pressures rise thanks to cardiopulmonary bypass preload, oncotic pressures drop, hemodilution, bye-bye albumin. Unless we give albumin in the prime, a lot of places don't do that. I'm glad we do it, but there are places that don't give albumin due to its cost. It's expensive.
It really isn't.
They like to say that though, even though we have so many more expensive things, but they want to point out the albumin. Mm-hmm. And you're right. On the grand scale of all the things we do in the OR, it's really not.
No.
Endotheliums can get leaky. Cytokines, they rave. They have their own little party. The result is fluid leaks out, hangs out in the interstitium, and your patient becomes swollen, but paradoxically hypovolemic. That's the weird thing about it is they're actually hypovolemic despite having all this fluid everywhere. This is when you need the perfusionist to say maybe it's not more about the fluid they need, but a better understanding of what's actually going on in the capillaries. You know what I mean? So that's all I'm going to say about that. I don't want to, again, we're going to move through these topics quick. We have a lot of stuff to cover. Renin-angiotensin-aldosterone system. When the perfusion drops, the kidneys, they throw a panic party, Renin kicks off a whole biochemical, cascade of events. All starts in the kidneys. Your JG cells detect a decrease of perfusion pressure. Again, I'm not trying to get that in depth, but that's what happens. And they release renin, which eventually will kick off angiotensin 1 to become angiotensin 2 under the enzyme ACE. But again, all that's not important. I'm trying to keep it light. So angiotensin 2 will tighten the arteries, kind of like a pressure cuff. That's kind of what it's one of its main effects, actually. Other than stimulating aldosterone as well, it'll also do that too. And aldosterone is like saying, let's keep every drop of sodium. So it'll act on the kidneys to retain more sodium. And with the sodium, water follows sodium. It's kind of just what it does. So you'll hold in water. This system's evolved to keep us alive in the desert. It's kind of, think of that. You know what I mean? So now it just makes the ICU patients puffy. So again, not the biggest deal. The real clinical pearl here is that in post-op cardiac patients, especially those on ACE inhibitors, which inhibit that angiotensin converting enzyme, the one that turns angiotensin 1 to 2, the system may be blunted. They can crash hard or need more vasopressors. And just for laughs, if the RAS system had a theme song, it'd be like Beyonce's hold up, because it never wants to let anything go. It's just how it's built. And that brings us to ADH. So ADH kind of works a little bit the same way. Its name exactly tells you what it does. It's like your body's overprotective roommate. It's the anti-diuretic hormone, and it's going to make sure you don't diurese, make sure you don't pee, make sure you don't excrete water, but hold on to it. So it sees a little dehydration and it locks up the bathroom. It's like, nope. ADH is triggered by high osmolarity, low pressure. So osmolarity, I didn't touch on what that is, but osmolarity is, if you have to give it a very basic definition, it's just the amount of stuff in a fluid. The more stuff, the higher the osmolarity. The less stuff, lower the osmolarity. That's a simple. Obviously, it has a much more drawn out, definition, but that's in the simple sense. Know that, and it'll make sense to you. So, ADH, what does it do? It can act on the collecting ducts in the nephron, okay, to reclaim water and to concentrate urine. But under stress, like surgery, anesthesia, pain, it kicks into overdrive. So what's the result? Low urine output because it's going to take everything back in. Water retention, again, taking everything back in. Dilutional hyponatremia because it's taking everything in. All the sodium we have is now diluted through all that water that we just took in. So if a patient looks fluid overloaded, but isn't making urine, don't reflexively reach for a bolus. Think, is this not an ADH problem? So fun fact though, ADH doesn't actually carry water. It just sends like a pervasive text to the kidneys, please keep me to the kidneys, keep water. Like that's kind of how it works. So this is just a brief on what Joe's topics are going to be later on. Ultrafiltration, modified ultrafiltration. Let's be honest, sometimes we just get too much fluid. It's just the way it is. Other times the body hoards it like a bad episode of, like extreme water retention. Ultrafiltration can help us fix that. Standard ultrafiltration, most of you, those that have been in an OR with a pump, you guys know what that is. It's used during cardiopulmonary bypass to control volume and crit. They're called hemoconcentrators. That's what they're doing. They're pulling off water to concentrate the hemoglobin. Its name tells you what it is. So there's another type, modified ultrafiltration. That one kind of is post-bypass. Again, I'm going to keep this general. Joe will probably talk a lot more about this stuff. That one's a little more fancy, The other one does it too, but modified ultrafiltration, we kind of do it to pull off inflammatory mediators, concentrate blood, improve oxygenation. And it's very routine in peds cases. I mean, those guys they love that stuff. In adults, probably should be more common. It's not. One case me and Joe did together, Joe had made me do it.
What happened?
Modified ultrafiltration, where we were ultrafiltrating after we came off pump.
Yeah,
we ultrafiltrated all the way to the end.
Actually,
like right until I gave the last little 50 cc's of volume, and he just kept on going.
Yeah, so
we clamped it right before we started vortexing.
Yeah. So what I like to do though, like today, I did a case today, the one at Cypress,
right?
The new hospital, and everyone, you can send your congratulations to me. You can, because I defeated everyone getting there, and I beat them all, beat y'all. If any of those you watching, I doubt they are, but nevertheless, I don't think they watch us.
That's okay. We beat the big boys,
But I came off.
David Goliath.
I did.
I
did.
It's nice.
I did, and did it because of just hard work.
Yeah, exactly.
Hard work, good reputation.
There you go. See?
Anyway, we came off pump, and we had probably, I don't know, I probably had 800 in my reservoir, and the venous line wasn't out yet. So I just hooked the waste container, the suction up to sub vacuum. And just ran it through the hemoconcentrator and just took the volume all the way down to 0.
Yeah.
And then I added the crystalloid and chased in all of that blood.
Right.
And
it's like super good.
It's super concentrated.
They call it good, but that's like super good.
Well, it's kind of like the concept of Keith Samolik's hemo bag. Have you ever seen that? You seen the hemo bag?
No.
So the hemo bag it's a very interesting idea. I think it was a good idea. I never used it, but it was perhaps it doesn't have as much utility today. I can't really tell you, but nevertheless, you took the post pump volume and you recirculated it in this bag and hemoconcentrated it in that way, and then you give that bag of whole blood, concentrated whole blood back, and of course you have preserved everything.
Right.
Well, I did the same thing. I just didn't do it with a bag. I just did it with the pump.
Right.
And got all the pump volume in, and watched the hematocrit. We came off pump with a hematocrit of 24, and we went out of the room with a hematocrit of 29.
Wow.
It made a big difference.
That's a huge difference.
And we only had one. We had one not completely full cell saver unit. So I put and that's 225 volt. But it was probably about 175.
So that's good. You're able to give it back directly to the patient
Right.
instead of washing out all the good stuff that the cell saver will wash out.
It makes a huge difference. Absolutely makes a huge difference.
Especially on like post-op coag profiles too.
Right. I don't call that muff.
Okay.
I don't call it muffing because really all I'm doing is concentrating the pump.
Right.
I'm not really taking from the patient, concentrating like we did in those days.
Yeah.
I just do it during the entire procedure.
Yeah, you do it during the entire procedure. Correct.
And it's really amazing to me because, I'm going to have a lot to say during my lecture, some of which is going to be somewhat controversial, but then that's, sort of where I'm at, what I am like. I sort of thrive on controversy. You know that.
That's your bag.
But people that, try to convince me that ultrafiltration somehow reduces urine output. Well, I kept this patient per the physician, the surgeon's wishes, kept his mean pressure at 90, 85 to 90.
God, that's high.
And but it's not. It's normal.
94 is normal, correct. If you have normal blood pressure,
And
your map would be 94.
Right, but if not, it'll be
at
higher.
120 over 80.
It'll be higher if
It'll
you're
be higher.
hypertensive.
Right.
So we are constantly perfusing at a far lower blood pressure than the patient is used to.
Right.
It isn't just the pulsatility that's gone, right?
No, yeah.
And so, anyway, this patient made urine, like gobs of urine all day. And I've always known that we run our pressures too low. And if the kidneys are used to that pressure head, they're going to sense that something's wrong, and they're
Right.
going to react, which I think maybe you can even elaborate on a little bit.
Yeah.
And so that's, I think, why we see reduced urine output intraoperatively, is simply due to decreased overall perfusion pressure. That's what I believe.
And it comes down to, the JG cells that will detect the lower flows, the lower pressures, and I just got done telling this audience what happens. What are they going to do? They're going to secrete renin.
Yep.
That's what's going to happen. And that'll happen every time. There's no off switch to that.
Yeah.
If they detect the low pressure, if they
Which
detect
means
low
they're
flow,
going to hold on to water.
Water. They're going to constrict
Right.
your blood vessels.
Right.
They're going to do all kinds of fun stuff,
Right.
So
Right.
I see what you're saying.
And that's that organ crosstalk we've talked about.
Exactly.
The
that we
kidneys
touched
talk
on.
to the blood vessels, talk
Yep.
to the heart. The brain, the heart talks to the kidneys. The heart talks to the brain. The brain is even talking to the
Right.
heart and the kidneys, right?
And AT2, angiotensin 2, is a powerful vasoconstrictor.
Oh, it is.
It's a super powerful, and it's not selective. It just goes around constricting everything. It doesn't care. So yeah, I mean.
So sorry.
No,
Go ahead.
you're okay.
I'm sorry.
So yeah. So okay, we'll move on. I'm gonna let Joe deal with modified ultrafiltration and I don't want to step on his toes.
You're not.
I know. I'm
No,
not.
you can step on them.
I just wanted to bring it up because
No, do it.
that way I could I told you I was going to segue into yours. Remember?
Yes.
All right. So hemodynamic monitoring. I'm going to go a little bit more in depth about this. This is just so I can touch on some stuff. So when I say these terms later, as this thing goes on, you're not confused about them. If you're only using CBP to judge fluid status, it's like checking the weather by sticking your hand out the window once. You know what I mean? Like, it's not going to tell you much. CBP, it's easy, but it's unreliable. There's other dynamic measures, SVV, PPV. Tell us if your heart, will respond to fluid. Echo is huge. TEE is huge, It's like real time. So that's what makes it great, Something like if your SVV is greater than 13% in a ventilated patient, they're probably fluid responsive. Your role, help the team interpret these numbers in context. Be the person who says, yeah, the CVP is low, but the SVV is good. So the echo says they won't benefit from more volume. So we're good. Be the difference between like routine perfusion and excellent perfusion is this: being able to. I said it yesterday. You gotta read the room. You gotta know more than just one number. The body always tells you a story, and it doesn't just give you one piece. You gotta go. It'll give you a lot of signs. Our body, as Joe kind of just said right now, it talks to itself. When one part's unhappy, believe me, it'll make everything around it unhappy. You're gonna have multiple lab values not in range. It's just the way our bodies work. We work very well under homeostasis, equilibrium. The minute we fall out of that, it throws off everything. So just keep that in mind. I don't want to say too much about that because I said a lot about that yesterday. So inflammatory fluid shifts. Once inflammation kind of breaks the rules. It opens endothelial gaps, allows fluid and proteins to leak out. Think of like capillaries as like coffee filters. The inflammation like turns them into sieves. You see patients with massive edema, weight gain, low albumin, but shockingly low urine output. That shouldn't happen, but it does. This is classic third spacing patient. We experience this a lot on pump. Those that have pumped know this. We give them albumin halfway through, try to get some of that back. you can give them 5 liters, fluid, and you'll still look dry. Why? Because the volume isn't where it needs to be. It's in the third space. It's gone. It's just not where it's supposed to be. In these cases, think like a plumber. Don't pour in more water. Fix the leak. Seal the pipes. Use vasopressors to maintain flow. Things like that. Just think outside the box. Fluid isn't always the answer to a fluid problem.
Well, even if it is, which fluid?
Exactly. And then there's that, they're not all
And
equal.
there's that.
And we'll talk about the different types. There's 3 or 4 different types of fluid. You can't just give one. There's rationale, So fluid dynamic responsiveness. So this is $1 million question. Will giving fluid help? Kind of like I just said, if stroke volume increases after a bolus or like a passive leg raise, then the patient is fluid responsive, If it doesn't, then, you're just cause dilution and edema for nothing, This is why SUV, PPV, and bedside maneuvers like that, like you'll see them occasionally, especially coming off. Like you'll see the anesthesiologist, like one time we were about to leave the room and they'll just come and they'll lift up the legs, see what happens, see if they can't get that pressure to recover a little bit. Move the fluid out of the legs, push it towards the heart. Trendelenburg positions, all these things, they all work on that,
Mm-hmm.
We do it all the time, head down. You can't tell me you haven't been through an operation where they don't say that. It's the logic behind it. Positional maneuvering, So even something as simple as lifting the legs can stimulate like a fluid bolus, or Trendelenburg or anything like that. It's literally a shot of fluid. That's what you're doing. And you're moving a good amount too often, It's like dropping in 500 cc's to a liter. You'd be shocked, You'll see it. I mean, I don't have to tell you guys. Well, sometimes your map will be like 35, 40. They'll be deep head down and boom, all of a sudden you're good. Like, you'll gain 30 points just like that. And, you'll see it. So my motto, fluid is a drug. Just remember that, you know what I mean? It needs an indication, a dose, monitoring. You wouldn't just give epinephrine blindly, right? You wouldn't, right? So don't do that with fluids either. You have to understand that we bill for them like they're medicine, so treat them like they're medicine. So I'm going to go through. We're actually decide. I'm going to cover these at the end, the cases. So let me move over to here. So that is 16. We'll come back to the cases at the end. So the overview of fluid shifts. So let's break this down, all right? Fluid shifts refer to water moving between the compartments. Intravascular, interstitial, intracellular, extracellular, okay? These shifts are driven by osmotic gradients, mainly sodium, proteins, things like that. Hydrostatic pressures, like I mentioned earlier, fluid pushing out the vessels. Capillary permeability, often it's increased, during like bypass or inflammation. So those play a little part in what we're going to do. So why does this matter? So if you give like an isotonic fluid, so isotonic fluid means that it has the same tonicity or osmolarity as we do. And when I mean the same, I mean about the same, okay? Because they call normal saline an isotonic fluid. It's not. Okay, it's slightly hypertonic. They call D5 it's isotonic. It's not. It's slightly hypertonic too. But it's close enough that they get away with calling it that. Like normal saline is 308 milliosmoles. Our body's 300, so it's a little bit more, has a little bit more stuff inside than we have, is what I'm getting at. You know what I mean? When I mean stuff, I'm talking about electrolytes, stuff like that. So if you give an isotonic fluid, keep in mind that it mostly stays extracellular, okay? 75%, because it's isotonic. So the way fluid will move is through tonicity. It's the laws of osmosis, okay? Fluid likes to go from a higher osmolarity to a lower osmolarity. So if it's got, the best way to think about this is if you have two fluids and one of them has a higher osmolarity than the other one, then this one has more stuff, right? So if it has more stuff, then it probably has less water because all the space is being used up by the stuff. So it has a lower concentration of water versus the other one will have a more higher concentration of water. So it'll go from water is like any other thing. It wants to equivalent. It wants to become, equal. So the osmolarities drive water shifts like this. Okay, they're going to want to move just like that. So a hypotonic fluid, okay, is a fluid with low tonicity. So it has a low osmolarity, lower than our bodies. So lower than 300 or, ish. They're going to want to push fluid into the cells. The way you can remember that one is hypo is like a hippo. Hippos are fat, so it'll make the cells fat, okay? Hypo-hippo. Hypertonic fluids are the opposite. They have a tonicity or osmolarity higher than our body fluids. So probably higher than 300, like colloids and stuff like that. They're just going to be much higher. So those will pull water out of the cells, Why is this important? Because certain cells, they just can't deal with it. You put RBCs in a hypotonic solution long enough, they'll hemolyze. They'll pop. The water will just keep going in and they'll just pop. Next thing you know, you got hemolysis created by a fluid. You won't, people like to blame pump heads and this and non-coated circuits, and it could just be the fluid you gave. Now all of a sudden you gave too much hypotonic half normal saline, and now you got hemolysis going on everywhere. You probably grabbed the wrong saline, thought you were grabbing normal and grabbed half normal on accident, and boom, now you got a problem. So keep that in mind, Also, these fluid shifts can cause edema, like I was just briefly said earlier. Cerebral edema, hypotonic fluid can cause cerebral edema. The beautiful thing is if a hypotonic solution can cause cerebral edema, then a hypertonic can reduce it, right? Because it'll pull the fluid. So we can use those medically, and they do in the ICU. We don't use them on pump too much, but we do use them. I'm not saying we don't, but not for cerebral edema. So mannitol, we use mannitol, which is a super osmotic solution, very highly.
They'll infuse mannitol continuously in a closed head injury.
Yes, they will. That bag, the 20% bag, they'll just let it go.
Hypertonic saline, another way of managing
it.
Yeah,
3% saline, correct.
Aggressive CRRT to keep the fluid
low,
balance low.
Yep. So all these things we do regularly. Again, not so much always in the OR. We do a lot more. A lot of the stuff I'm going to talk about today is also ICU stuff. A lot of fluid management happens in the ICU, so you'll hear me talk about bedside. You'll hear me make stuff like that. You'll know when I'm talking about the ICU. All right, this is it. The Darrow-Yanit diagram. Let me get my pen out. All right, so this diagram, as simple as it is, it taught me everything I need to know about fluid movement. It's the way they do it in med school, and it's the way I'm going to teach you guys today. I shall pass the buck. So, what you do is, again, this is a very simple graph. The x-axis, oh boy, hold on. This axis here is volume, okay? Keep in mind that this side is not zero, so this side is not negative, and that's not how it works. So if we figure out volume expansion on the ICF, we will draw it this way, that the volume expanded. So the bottom is volume, and if ECF expands, we'll draw it this way, okay? This way, the y-axis is tonicity, okay? So again, simple. The very first thing we're going to do, I have slides for each one of these. So first I'm going to walk you through all of them on this one particular slide, and then we'll go more in depth. Right now I'm just going to talk about, like, what if we add a hypotonic solution? What if we add an isotonic solution? What if we lose one? Later on I'll tell you the examples, and we'll go more in depth on each one of those, But for now, let's just talk about just the way the fluid shifts. That way I can walk you through it. The other ones have all the answers, and then you'll be cheating. So, okay. So the first one let's do is isotonic gain. Hold on. Okay. So what did I tell y'all before? When we give a fluid or anything, where does it go? It goes into the intravascular and then to the interstitial or whatever, but this graph is very simple. We're just going to call it the ECF. We don't need to break it down any further than that. Okay, this again, we're just trying to figure out on this graph, we're just going to be determining the relationship between the extracellular fluid and the intracellular fluid. We don't care about anything else, okay? So is it going to go into the cell or pull it out of the cell? And what's going to happen to tonicity? That's kind of what this graph does. So, okay, so isotonic gain. So we have given a isotonic fluid. Well, what do we think is going to happen to tonicity? Well, it's isotonic, so tonicity is not going to change. Oops. So it will stay, wait, what's going on here? It will stay the same, the tonicity. It's not going to go up. It's not going to go up. It's not going to go down. It's just going to stay the same, okay? And so, since that's going to stay the same, do we think any type of fluid is going to shift anywhere? No, because the tonicity is the same. I told you guys that osmolarity, concentration of solutes, that is what causes fluid shift. So for this, nothing's going to go anywhere. So you're going to get a volume expansion just in the ECF. So the way we would do that is like such. Let me draw it in red. Boom. So the ECF volume expanded this way. That is a volume expansion, okay? That and the tonicity, which is here, is the same. Okay, that is isotonic gain. We add any isotonic fluid, it'll stay in the ECF. We know that. It's not going to go nowhere. Why do you think that when you go into the ICU and you go in with a massive bleed and they got to give you something until they get the blood? What do they give you? Isotonic saline. That's the reason they do it. It'll stay there. It's not going to go nowhere. It's going to stay in that compartment and expand the volume of that compartment, which is what you need at the moment of, so you don't go into cardiogenic shock. So next, let's talk about isotonic loss. Well, the beautiful thing about isotonic loss is it's exactly the opposite of isotonic gain. So for this one, again, tonicity is the same. Okay, we're not changing tonicity, right? That will stay here. But this one, you lose volume, so it's not going to expand out, but it's going to contract the ECF. The ECF will actually get smaller. So this is now the new ECF right here. So that's isotonic loss. Again, easy. These are easy because there's no fluid shift. Now we're going to talk about some fluid shifting stuff. Now it'll get a little more complicated. All right. So let's do hypotonic gain. Okay, gaining a hypotonic solution. Again, I'll walk you through what this. It's like giving half normal saline, like I briefly alluded earlier. There's a bunch of hypotonic fluids, but this one is a popular one that sits on our shelves. So you might see it 0.45% saline. So
they have 3% here.
No, that's hypertonic.
Oh,
Yeah,
you're saying 0.4.
I'm talking about half normal. Yeah,
0.45.
we're talking about hypotonic.
I'm sorry.
Yeah,
I'm
you're
sorry.
okay. You're okay. So yeah, this is 0.45. Joe didn't hear me.
Half normal, yeah.
Half normal, correct. Half normal saline is what they'll call it. If you give it a name, nobody's going to understand, but this is just what you'll see on the bag. You won't see half normal saline written on the bag. All right, so we are losing. The very first thing you do when you think of Darrow-Yannet diagrams, again, always think of tonicity. So we're gaining a hypotonic solution. So what will happen to the tonicity if you're gaining a hypotonic solution? the tonicity will go down, okay? So tonicity comes down, okay? The tonicity comes down. Why? Because you're gaining hypotonic. So you're gaining a solution that's less tonicity. So obviously it's going to bring the overall tonicity down because you're now adding less. So imagine this is all 1 and then you add a half into the 1 and you multiply it. You're not gonna end up with more, you're gonna end up with less. So that being said, the next thing you're gonna want to do when you think about this is think, okay, so now our tonicity has gone down. Our overall is hypotonic. Where would fluid shift in these situations? Well, I had briefly told you, hypo-hippo. It's going to go into the cells. So the fluid shift is going to be intracellular. Okay, so fluid shift will go that way. Oh, yeah. That's okay. What is it? The battery dead?
It's not really.
All right, cool. All right, can you guys hear me? All right, cool. All right, so for this one, we know that fluid will shift into the cells because we have brought the tonicity down. Okay, the overall osmolarity, the concentration of solutes, we have brought it down. So fluid will move, and we have gained fluid. So we're gaining here, right? And we have gained fluid here. So here's the beautiful thing that you need to understand about Darrow-Yanit and in general about anything that we do. The ECF, if you gain fluid, see these arrows, you would think that, oh, well, we gained in the ECF, but it's going to all go to the ICF because it's a hypotonic solution. No, that's not. They get to equilibrium. So you're still left with some in the ECF. They'll just balance out. So you're still left with some in the ECF, and then you'll gain in the ICF. So you'll get an ICF gain and an ECF gain. So the ECF will gain, the ICF will gain. Again, remember how I told you guys that, hold on. That this is a gain. Again, this is not negative. This is just how we would write a gain. If I wanted to write that the ECF lost volume, I would come this way and make a line here. Okay? So the ECF gained, the ICF gained, and the tonicity came down. So boom. That right there is what your new compartments would look like. Lower tonicity, expansion on the ECF, expansion on the ICF. That's the Darrow-Yanit of hypotonic gain. Okay? Let's move on.
They take a week and a half to teach this?
What do you mean?
You just taught it in 15 minutes.
Oh, no. There's 4 of them, 5 of them. But yeah, I know it pretty well. That's why, Joe. I spent a good man, this thing blew my mind. I mean, it probably is going to blow some of your mind. My mind was blown the first time. I just couldn't understand it. It took me some time to figure this out. It took the right teacher. The first teacher I had, he just didn't explain it right. He didn't have to draw all these fun little arrows that I'm drawing for you guys to, I don't know. I'm just teaching you the way that one teacher that finally made my light bulb turn on, he taught me. Oh, whoops. Alrighty. Moving on. So now we're going to talk about hypotonic loss. Okay. So, again, address tonicity, right? That's the first thing we do. What's happening in hypotonic loss? So they're losing a hypotonic. With losses, just remember that the tonicity goes opposite. Okay, so if you're losing hypotonic, then what you're left with is more hypertonic. So hypotonic loss is just like losing water. So you're losing water, but you're not losing any of the sodium or any of the other the stuff that gives it its tonicity. So your, oops. Tonicity will go up. Okay? So now if we have a higher tonicity, which means that our ECF is now hypertonic, what's going to happen? Well, I told you guys, the cells, they shrink. So you're going to pull fluid from the cell to the extracellular compartment, make the cell smaller. It's the opposite of hypotonic. So in these, the fluid will come this way, from ICF to ECF. Okay? And that means that, again, we gave this fluid in the ECF. So we know that the ECF gained some volume, gained some space, right? We gained volume on that one. But here, hold on. I could have drew that a little bit better for you guys to make it a little more clear. Here we go. This is the first time I'm teaching this to people. So we gained fluid here. But we also gained fluid from the ICF, okay? So we're going to gain a little bit more fluid. So this expansion is quite larger. ICF lost fluid, so that one's line will be like here now, okay? And the tonicity went up. So we're going to come up on tonicity. We're going to come out this way, and a big volume expansion like that. So we have a lot more ECF, a hypertonic solution now, and we have a lot less ICF. That right there is hypotonic loss. Okay? Hopefully by the end of these it'll make sense, because I'm going to do all these, all 6 for you. Usually we're going to... So now we did both hypotonics. Now we're going to do hypertonic. We'll do the easy one first. I call it the easy one because there's no opposite, there's no rules, but hypertonic gain. Okay, so gaining hypertonic solution, so obviously what's going to happen to our tonicity? It's going to become more hypertonic. So our concentration of solutes is going up, our tonicity is going up, our osmolarity is going up. So we know that it is going up. And again, we just did a hypertonic solution, so where is the fluid going to shift to? It's going to come out of the cells. It's going to make the cells shrink. So we know we're going this way. Okay. And again, we're gaining. So this one's almost like the other one, see? Hold on 1 second. Okay, so just making sure that I got this part right. Yeah. So there you go. So again, this one was the reason I called it the easy one. So I realized I did the other one wrong. I'm going to do it again. The hypotonic loss.
Can't do it wrong.
Oh, no, I can. This, like I said, it's my first time teaching it. So the hypotonic loss would have looked like this. Is the ECF would have had a loss. Okay, and then the fluid would have went this way. The hypertonic, the ICF would have lost. It would have looked like that. Okay, that was hypotonic loss. Because you're losing here. I wrote it as a gain. because this one you didn't gain, you lost fluid. So in that one, in hypotonic loss, we go this way. Again, it's been a while for me to do this, but here I am doing it. And then our osmolarity went this way, and it pulled fluid out of the cells into this. So you lost here, but you gained on tonicity because it became more hypertonic. Okay, so let's do hypertonic loss now, which is the last one of these, and then I'll go a little bit more in depth on for you guys. All right. So again, just like that last one, it was this hypertonic loss that made me think about it. That made me think, oh wait, the volume expansion was wrong. The volume contraction of the ECF was wrong. I showed a gain, but it was a loss. So this one is also this. It's kind of like hypotonic loss in that it will be the opposite. Okay, so, whoops, did I change color? I don't want to change color. I liked red. All right, here we go. So this one is hypertonic loss. All right, so for hypertonic loss, again, it's a loss, so we know the ECF is going to become less. Okay, so a hypertonic loss. So since it's a loss and we're losing hypertonic solution, the overall osmolarity of what is left is hypotonic. Okay, so we know that the osmolarity will come down. All right, and since the osmolarity is coming down, which way is fluid going to shift? Well, this is the dangerous one that I always talk about. You know, this is the one where it's going to go into the ICF. This is the one that usually you got to be very careful with. It's never a good thing. So, okay. It's going into the intracellular fluid. So we have a decreased tonicity. We have fluid shifting into the ICF. So how would we draw this? Again, it's a loss, so we know we're losing. It's a decreased tonicity. So, and since this is increasing, the ICF, we're going to increase here on the ICF. We're going to come out that way and boom, go like that. And that is the graph for hypertonic loss, which shows, of course, the decreased tonicity, the decrease in the extracellular fluid, and the increase in the intracellular fluid. So that's the 6. Now,
so can I ask you this?
Yeah,
I
absolutely.
hate doing this. Please forgive me.
No, you're okay.
Again, you know, I mean, I understand these concepts, but I might not be understanding this. But if you're giving hypertonic,
we're losing hypertonic.
You're losing hypertonic loss. Okay.
Correct.
Hypertonic gain, this would be up here.
Exactly.
Okay.
Correct.
Okay.
So since we're losing hypertonic, we're left hypotonic.
Loss. Okay, gotcha.
Right.
Gotcha.
So again, hypertonic loss, hypotonic gain, those are our hypotonic states that will increase cellular swelling, stuff like that, hemolysis. Those are the ones where you really got to pay attention to what you're doing, because those can result in something real bad, cerebral edema. These are the dangers too of the two. We'll get to all that now. So here they are, fancily done. Individually, I'll talk about each one a little bit more, give you like examples and stuff. I kind of wanted to walk you guys through it, how it works and how to draw the diagram, so I stuck to that first slide. Because this one has it all drawn out for you, and I don't know how to explain it to you from here. I can just talk you through it, but talking you through it and seeing it done is, like Joe said, sometimes you just got to see it, you know what I mean? And talk. Like those two together, words with action really means a lot. So, okay, this right here, gaining isotonic fluid. We talked about it, like it's like filling a balloon, you know, you're just going to expand the ECF space, mostly the interstitial, the plasma. This is your go-to for most resuscitations. I briefly mentioned it. You know, the plot twist there is that only 25% stays in the vascular space. The rest is going to go into the interstitium. So remember that, you know. But again, your patient's bleeding out, then you don't exactly have a choice. You kind of to stabilize them hemodynamically before you get blood products into the room. You gotta give something. So they'll just rush in normal saline or any type of isotonic fluid that they got, and they'll just push it until they can get the blood in. You know, so it's used for hypovolemia, post-op losses, GI bleeding. But beware, though, like I said, too much of it will go into the interstitium. It's going to lead to edema, poor wound healing, you know, delayed extubation, stuff like that. Fluids aren't harmless. Like I told you, they're a drug, you know, and dosages matter. You know, so again, as I briefly told you earlier, this one, you just kind of are expanding this way. Tonicity here stays the same. We're not really doing anything, right? We're not changing tonicity. It's an isotonic fluid. So you have your expansion here in the ECF. I wish I had better handwriting. I do not. I was a doctor. We just don't have the best handwriting. Sorry. So, isotonic loss. So imagine a patient is leaking fluid but keeping the sodium in name range. That's isotonic loss, you know? Like this happens usually in hemorrhage and diarrhea, burns, you know? You lose both sodium and water together, so, you know, osmolarity stays stable. So what do you give, you know, in isotonic loss? You give isotonic fluid. You know, that's kind of what you give. So, but remember, you know, assess the response. Not just look at the don't just look at the BP, look at the lactate, the mental status, you know. So we're trying to move past just give a liter. So again, in this one, vomiting also can, you know, be included in here. Diarrhea, you know, can be in here. These are isotonic loss. So in this, again, we're going to move here. This little dotted line is the new, this line right here is the new compartment. So again, like I said, tonicity is the same. Volume, compartment contraction, I guess is the actual words, but your ECF just got smaller because you lost anything and doesn't move anything around. All right, so gaining hypotonic. So this can happen like if you add like, you know, D5, you have a case of what's called SIADH. Those guys just have way too much like ADH. They just start pulling in a bunch of water from their kidneys. They just don't pull in enough sodium. It just pulls in water, lots of it. In our case, in the cardiac rooms, it can happen from right heart failure. You know, it dilutes the serum sodium, you know, because you pull in all this water. You pull in the water into the cells, brain cells, you know, again, this one is one of the bad ones, the one that I was talking about, you know, it's gaining hypotonic fluid. You're just that water is going to go everywhere, and especially into all kinds of cells. They're dangerous in neurosurgical and cardiac patients, especially right heart failure patients. So you want to stick with isotonic fluids for these types of patients for this compelling reason, you know. You always want to check the sodium on these patients. Make sure that you're not falling behind and getting the body into a hypotonic state. You know, and you don't, you know, you pay attention to the numbers. Like I've said, and I'm going to beat this into you guys, it's what we do in medicine is about the numbers, and not just one, but the whole collection of them, you know. And this one is not just about the sodium, but you go and you look. What's going on? Does he have mental status changes? Does he have anything to signify that there's some neurological edema going on? And does he have any trouble breathing? You know, like what's going on? Does he have pulmonary edema going on? Let me see. Look at the signs. Look at the symptoms. Look at the numbers. Once you put the whole story together, if you know what the numbers are and you can see the signs, it's very easy to know what's going on. Especially with this. With hypotonic, you figure it out because it messes stuff up real bad. So again, in this one, we gained a hypotonic, right? So our tonicity came down right here. We gained on the ECF, but because our tonicity went down, we drove fluid into the ICF here. So we had ICF volume expansion here, overall tonicity decline, and ECF volume expansion as well. Because like I said before, just because the fluid is going this way, all of the fluid doesn't go that way. You know, it's going to balance out. Oh boy. I don't know what I did.
What happened?
Hold on. I think I just got to push a button, slideshow.
Oh, here. Let me see. Let me see it. Present. Here, let me just see.
Oh God, Joe. Here.
Yep.
There it is.
We know where
Perfect.
it is. Relax.
Thank you.
I got it. Everybody calm down.
Calm down. I put
Joe's
my
here.
palm on the screen. I'm trying to like hover above it, and it's hard. Every time I touch it with my palm, either the keyboard comes up or something happens that I don't want to. So you guys will see me fiddling here on this iPad a lot.
Really?
Which is, you know, oh, look at you. Okay. So that's gaining hypotonic. Let's talk about losing hypotonic. Okay? So this actually is the wrong graph. Because if you lose hypotonic, you stay hypertonic. So this one would actually be like this. Hey, how about that? I found a mistake on this guy's slides. Because you're losing hypotonic fluid.
You're teaching us, dude.
Absolutely. So yeah.
Don't make statements
Yeah.
sound like questions.
Yeah. This guy's wrong, but that's okay. So in this, you got like, you're losing hypotonic fluid. It's stuff like loop diuretics, stuff like that, Addison's disease, you know, diabetes insipidus, DKA, you know, stuff like that. Where you're mostly losing water, you're retaining sodium, you know. And since you're retaining that sodium, again, it makes my point for me that this graph is wrong. You don't, the osmolarity doesn't decrease. See, now I'm glad I drew it out for you guys first. Before we got to the slides, see? Because this guy, if you're losing hypotonic fluid, again, it goes without saying that what you're left with is more hypertonic. It cannot possibly be hypotonic. You lost water. So if you're losing water, you're left with solutes. So again, the tonicity will be higher. You would have a volume contraction here because we lost hypotonic. So this one would go there. Because it's hypertonic, you would go this way. So this one would actually come here, like such. Okay? That's the way it would be right there. Let me... There we go. Boom. Okay. So we're gaining hypertonic now. Let me get to that. All right. So how do you gain hypertonic? Like Joe had briefly alluded to earlier, mannitol drips, bicarb drips. In the OR, we like to give a lot of mannitol on pump. You know, that'll do. You don't, but people do. 3% saline, as Joe had briefly touched on earlier as well. These are all hypertonic solutions. They raise your serum osmolarity. They're great for pulling fluid away from stuff like cerebral edema. Anywhere where you got edema going on, it can pull that fluid out. Sounds great, right? But no, you got to watch out too, because you have to monitor sodium closely, because you do this too fast of a rise, and you can cause like osmotic demyelination of your nerves.
You're gonna die.
Yeah, which is very bad. Anything demyelination's bad.
Up, correcting. You got a mic. Turn on your mic. Up correcting. Sodium is a very treacherous thing. And there's a formula, right, that y'all have to follow.
There is.
Yeah.
Sodium in general, it's very touchy-feely. You gotta be real careful, because it drives all these fluids and everything. So you gotta be real careful on how you do it. You know, use your institutional protocols, whatever they are. They got them. Trust me, they're there. Talk to your anesthesiologist. He'll tell them to you if you don't know them. Those guys, you know, Tell them you know your diuretic after this. They'll be impressed that you know it. You know, you want to aim for serum sodiums between 145, 155. That's just kind of where you want them, you know. These are general normal range. Sodium does not play well outside of its normal range. Remember that. You know, there's a lot of electrolytes that you can go a little plus minus on. Sodium, potassium, these two, both of them, man, they do not like being outside of their normal ranges at all. You know, so that's just the way, that's the name of the game for those two. Watch your volume status, you know, and hypertonic.
You know, that's such a, please forgive me,
Yeah.
I don't mean to interrupt you, but I mean, you bring up such a very interesting point. And, you know, having a very high sodium being hypernatremic is not good.
No.
You know, for, you know, but we see it all the time when you do, for example, ultrafiltration, Z-buff.
Oh, yeah.
And you're using normal saline and bicarb.
Right.
Well, normal saline, 0.9, has 154 sodium.
Yeah.
So when you give just normal saline,
that 154 is half of the 308, by the way. Just I threw that 308 number out. Just wanted to tell the audience where the 154 came from. It's the sodium's weight on the osmolarity. Go ahead, Joe. Sorry.
Correct. And so, no, that's right.
Yeah.
So you are gaining
right.
sodium the more of that you use. So when you're doing Z-buff to knock a potassium down from 7 to 5, and you're using normal saline and bicarb is sodium bicarb. So now you're driving that sodium up. I've seen sodiums on just a simple Z-buff go all the way up to 156, 158 pretty routinely.
Yeah.
I've seen it. I've even seen it at 170.
I think a lot of people forget that it's sodium bicarb. You know, it's NaHCO3 minus. Like they don't. People get so attached to HCO3 that they forget about the Na part. You know what I mean?
It is sodium bicarb.
It's sodium
really going to
bicarbonate.
gain a lot.
And you're going to gain a lot, right?
I've seen it 170.
Right. And it's a super hypertonic solution.
Very.
Again, you know.
Now, transiently, I don't know that that's horrible.
Sure.
But you can't leave it like that.
No.
And it is a problem.
Yeah, absolutely.
And there's other ways to resolve that besides just using, I think, fluids and what fluids we use and why we use them, where we use them, when we use them is a very interesting topic.
Absolutely.
I enjoy the topic.
Right.
Forgive me, I'm sorry.
No, you're okay. So, yeah, sodium. Keep it in the range. That range is important. You know, Joe talked about too high. Too low is pretty bad too. You can start having seizures. All kinds of bad things can happen. You know, you a little bit low and you'll start yawning and have no energy, and too low and you'll be seizing. So keep it in range. All right. So again, here's our diuretic. This one's right. So again, we gained No, this one's not right either. So, yeah, okay. Gained a hypertonic. So we're going to go up on tonicity because we gained hypertonic, sorry. We expanded our ECF because we gained a fluid in it. And because the fluid goes this way from ICF to ECF, because we're pulling stuff out of the intracellular compartment, again, to help with edema, things like that, we have a contraction of the intracellular space. So here is your correct diuretic. Okay. That one is that one, and that one's easier. Okay, now I believe this is the last one. Losing hypertonic fluid. This one's a little bit more rare. It doesn't happen much. Again, Addison's disease, loop diuretic. Oh, so that's what it is that's why the other one was wrong, is the other one was, it was this slide. I think that was my mistake. I copied over the wrong slide. This one is right. This one is the loss of hypertonic fluid. So that's what it is. So it's, again, good thing I drew them out for you guys. In this one, you know, I'm a little bit more sneaky. Doesn't happen much, you know, but it can happen with Lasix. But usually we don't give that much Lasix for it to happen. But it can, is all I'm getting at, where you're losing hypertonic fluid. Okay, you're losing a lot of salt is being wasted, along with some water, but mostly cells. How's this? Adrenal insufficiency is Addison's disease. That's what that is, a decrease in adrenocorticotropic hormone, ACTH. Sorry. This one, again, you want to replace sodium and water cautiously. Again, anything with sodium, any type of sodium replacement, you want to do it cautiously. Oftentimes, you do it with isotonic or hypertonic saline. You can do it, but monitor the hell out of that sodium while you're giving it, especially if you're giving hypertonic saline, the 3% saline. Depending on the degree of deficit, you want to correct this very slowly. They don't ever go fast on this one. And again, you're losing a hypertonic, so we're decreasing tonicity. It's a loss, so it's going to go the opposite of we gain, so it's a loss, so we're losing ECF volume. And because we have lost tonicity, the fluid shift will be towards the ICF. It'll go into the cells. So ECF contraction, ICF expansion, and decreased tonicity. There you go. That one is that one. So, alrighty. That's the Diuretic, guys. Again, you're going to want to... It took me a few goes at learning that Diuretic. This is the reason they spend time with it in medicine. If you understand it, once you're able to understand it, it really makes understanding fluid dynamics easy, especially if it's the first thing you learn about fluid shift. See, that's how they taught us. They taught us that first. And then they taught us everything else. So then it just became so easy to understand everything else once we understood that. And that's kind of what I would want to tell you guys to do as well. If you're going to study on the Diuretic, figure the Diuretic out first. Then start talking about like some of the colloid, osmotic pressures, oncotic pressures, hydrostat. It'll just make so much more sense if you get into that after you've done Diuretic. Just figure out the effects of those three types of fluids on your body. If you start there, the rest becomes a piece of cake. Maybe that's why medical school does that. Because medical school definitely goes a lot more in depth than we do as perfusionists. Okay, they just do, and as they should, But I think that's why they teach the Diuretic first. Is it just makes that in-depth knowledge that you're going to acquire over the course of this whole thing is like a month long that they do fluids over there, and that's probably why. They teach you this. It's the absolute basics of fluid dynamics with regards to your body and the addition of fluids into your body. Okay, so let's move on out of that. Crystalloid and the colloid debate. This debate is older than some of the attending physicians, probably older than Joe over here.
I think so.
No. You've been around before the debate? After the debate, you're saying?
I grew up in a time when... I grew up in a time when albumin was
not really
considered.
Given.
Oh no, we were very
judicious,
liberal,
liberal,
very liberal,
very liberal.
I never saw a restriction of albumin until probably somewhere in the after the past 2005.
Mm-hmm.
Over the past 15 years, maybe
right.
15 years, I've seen it. 15, 20 years, maybe.
Right.
Yeah.
Right.
But no.
You don't think it's money related? Crystalloids are cheap for the most
albumin
part.
really isn't expensive.
But it's considerably more expensive than crystalloid.
But no.
If you had to compare the two.
Well, it is,
mm-hmm.
but you also have to use it. Yes, that's true.
But so's edema.
But
it's expensive too.
I mean, I think it's even, yeah, I think it's a lot more expensive.
Right.
I mean, overall, I mean, yes, it is more expensive, but the incremental increase in cost is just not that much. Not for
Considering-
what you're getting out of it.
Exactly.
I mean, we don't use it.
I'm
like-
a huge proponent of albumin.
I mean,
I love
you,
this stuff.
You only need, you know, usually, I mean, depending on whether or not you're dealing with a severely hypoalbuminemic patient, or you're, you know, somebody with really poor nutrition, or just bad liver, whatever. I don't know. You know, but you give it to try and normalize the albumin, just to keep the fluid from third spacing.
Sure. Because
so
we're going to
you
put a
don't-
lot of fluid into them.
Right.
Right.
So the amount of fluid we use, it's really, you can't look at it as that's going to be our
Right.
replacement volume.
No, yeah.
It's used to help you keep your replacement fluids where you want them.
Right.
Right.
That makes sense.
Right.
I agree with you. I mean, I like it. I don't know why. Well,
I think it's a grossly underused, and there's so much.
again, I've been to programs where they didn't allow it at all. Joe.
There's so much data, and I know, and I don't know how you do that. I don't really understand that.
Like, not even in the prime. I mean, we use 25 grams, you know, but they didn't use any.
Yeah, I just don't understand.
Not even like
that.
12 and a half. They just went with a fat zero.
Yeah.
They were okay with, you know, crashing the oncotic pressure. They were okay with the cop going down. They didn't care.
Yeah, don't agree.
Just, again, yeah, that's... So, again, crystalloids, cheap, effective, you know, rapidly they leave the intravascular space. Colloids are, per Joe, they're not expensive, but they're a lot more expensive than crystalloids. And I personally have not been in this industry long, and I have at least been to 2 places that just will not use it, and they quote expensive. And now, is Joe right? Absolutely. Everything in the
always right.
operating room is expensive. Like, literally everything.
No kidding.
Like, everything is expensive.
they're
That
using-
impella that they put in, like, without even thinking twice, expensive.
They
Like-
put in little plates in the sternum that are
Yeah,
$1,000
a plate. I know, exactly.
and they use 4
exactly.
just to close down. You're going to complain about some albumin on the ECMO? Come on.
And
I mean,
that's, again, what I've heard, you know?
ridiculous.
And that's what they say. So
it's
what do we
ridiculous.
use?
They're
you know?
just looking for what I consider to be the low-hanging fruit.
Right.
And so somewhere along the way, somebody read that bullshit Cochrane report
Yeah.
and was like, oh, my God, you die more often if you use albumin. Just use saline. It's better. Because that's what the Cochrane report said, basically.
And that's what the places I've been to, I guess they subscribed to that knowledge, and that was what they said. Well, just don't use albumin. It's too expensive. And the whole
Right.
time I'm thinking, but you just opened up that impella, like, you just opened it, like,
yeah.
with no problem. And you're 20 grand, and you're talking about like
20.
Impellas are 20, aren't they?
20.
20 is just the impella like unit. I thought that's how much they cost.
20 for those catheters?
No, like a 5.5, like the whole thing.
5.5 is like probably 70.
Good Lord, maybe they get a discount
Are you
over there.
kidding me?
This is at TMC, so
20? No, they ain't getting it for 20,000. I don't believe
no.
that.
I that's what they told me it cost when I was with the circ support people. I said, how much do y'all pay for this? And I was pointing at their wall that they have like freaking like 40 of them. Okay, this is like
Really?
Yeah, dude, they do a lot of them over there.
Yeah.
Like, I mean, a lot of them. And the rep told me that I think they put the most in. My brother-in-law, he puts the most in.
Yeah.
But yeah, so that's. I was like, man, $40. Like, how many is that? Like, how much money is that wall? I remember asking them. They're like, each one's 20 grand. That's
Yeah, I'm
what they
going to
told me.
look and see.
Yeah,
Go
check it
ahead. I'm
out.
gonna
Yeah,
check it
check
out.
it
I'll
out.
look
Check
it
it
up.
out. I'm curious too. That's what they told me. Maybe they were lying. Who knows? Again, I was a student at the time, so fluid overload. The slide is your, just don't mess up moment. Fluid overload isn't just puffiness. It can cause real harm. In the lungs, it can cause like pulmonary edema, prolonged ventilation. The kidneys, it can cause edema. Again, edema is like it can cause that everywhere. Which will impair filtration, worsen AKI. In the heart, it can cause RV strain because you're increasing volume. A tamponade, it can cause that. In the gut, it can cause, again, more edema, which will lead to poor absorption, increased infection risk. So, you know, these are the things that can easily go wrong. I mean, this is not like a small thing, is what I'm getting at. You know, you have to be careful, you know. So, like, with the lung, I mean, you just check. You know, you ever feel unsure, do an ultrasound of the lungs. You know, the crackles, they don't lie, and neither they. Oh, it's fun, but on the ultrasound, I actually have a slide of this. They make this little sunburst pattern called B lines. It's very hard to miss. Like, if you've ever seen them in real life, you know when there's fluid.
100 mLs of 25% is $38.
$38, and they're okay with opening. Man, you see.
And you're going to tell me.
I'm telling you, you know, because this is what I've been told. Don't open that albumin. Again, and I'm a student. I was a student at the time, so there's no arguing. Now I might be like, why? I'm gonna open it. Like, I'm worried about my patient, you know. But yeah. So fluid management in renal dysfunction. This is another important thing, because we have a lot of patients that come in with end-stage renal disease. They just aren't making urine, whatever the case, you know. The kidneys are like little fussy dinner guests, you know. They want to just get the right amount of volume and pressure. That's kind of how they work.
It's the 5.5 Impella at $2019 was $47,000 to $51,000.
So they told me 20 to 25 now. But again, they do high volume, so maybe they get a better deal on it.
Here's a 5.5 micro pricing report.
I know the CP is, and the CP is cheaper.
Yes.
Much cheaper. But I was specifically even talking about the 5.5, the most expensive one, you know?
Yes.
Like, that was the one I asked about, because I knew it was the most expensive one, because it's their newest one, right? Like,
I hate when they try to sell you the report.
Yeah.
Such bullshit.
I
think it's more than that. That's all I could say.
Yeah, I believe you. I mean, considerably more than the $38 that, you know, the albumin cost.
I don't think it's very much. I don't think it's very expensive.
No.
And I think it has to do with suppliers.
Yeah.
You know, they have distributors. It's all a system. And it's a really weird system, the way they have to buy
Abiomed,
it.
right, I think? Or
Abiomed?
No,
that's
who's
Impella.
No, that's Impella. That's what I'm talking about, Impella.
No, I'm talking about
Oh, you're talking about albumin. Okay, yeah.
Yeah, but the Impellas are more expensive than 20,000. 5.5s are way more expensive.
I believe
than
that.
Yeah, I don't believe that. They're about 70,000.
Damn.
I'm pretty sure.
70,000?
I could be wrong, but I'm pretty sure.
Dude, they just opened them up like
I know they do.
over there, like
I
it's
know
not
they
even
do.
a thing.
I know they do.
Like, it's crazy.
And you're going to be concerned about albumin?
They are concerned about it.
And that's what doesn't make sense to me. We'll talk about that. We'll get in. We'll talk about that.
It's an actual thing that's actually happening.
It is
Like,
such a grossly misunderstood thing, and
I won't say names,
and
but
the data
I can tell you who it is.
No, I know who it is.
Yeah, you know it good.
Yeah,
Okay, I don't bring up
and
the
the
name.
data is very. I mean, it's really, really, really good data. Like,
Right.
data can be good data, and data could be
Right.
not so good data. Right?
Right.
We all know that. They know the game. But the data is very conclusive, compelling. That an albumin level below 2.4.
Well, that's real low, Joe. You don't want that.
It's common.
It's common.
It's common.
Well, I guess once they get up to
once they imagine you have a dude.
That's so
I've
low.
seen it 1.2.
Yeah, I've seen that too. I've seen it real low too.
I mean, yeah. And the effect of that is profound.
Yeah.
And the predicted mortality, if you leave it, is outrageous.
Wow.
It's high.
Yeah.
It is an indicator. It is an independent predictor of death.
Wow. That's because, again, your fluid's not going to stay where you want it to stay with
That and you're really sick.
Your liver's probably not working at all. Like at that stage.
Some bad stuff wrong.
Yeah.
But you can't just leave the albumin.
No.
Because you're going to end up intravascularly volume depleted. And we're going to talk about that too.
Good.
Because when you say somebody is volume overloaded, what does that mean?
Right.
I'm going to talk about that.
Right.
That's part of my talk.
Well, good. That's I'm looking forward to your talk.
Okay. Are you happy that I had my microphone on, so you're not yelling at me anymore? Whatever.
For our audience, they said for him to turn it off. So yeah. Again, it's fluid. You want to manage it properly. You know, you don't want to wait too long to start dialysis if they're dialysis patients, which is CRRT. If the volume overload persists, you know, perfusionists, we won't deal with a lot of CRRT in the OR, but we will deal with it a lot when we do our ECMO stuff. So that's why I talk a lot about ICU. We are in the ICU too, you know.
I have pumped cases.
In the ICU?
With no, I've done that
like,
too.
that's crazy.
Well, no, I've done that.
Okay, yeah, not ECMO, but actual pump.
Yeah, it's pump.
Oh,
case,
nice.
Yeah. And I have actually brought a CRRT machine in the operating room several times and hooked it up and ran it through the entire procedure, right into the pump.
Nice.
No problem.
Through recirc?
Yeah.
Nice.
Run a line off.
Yeah, exactly.
Works beautifully.
Nice.
Yeah.
Yeah, I bet it would.
It did.
I bet it would.
It was great.
Oh, cool.
Sorry.
It doesn't need to be primed or anything like that, right? I mean, how much volume does it take?
At 280 cc's.
Oh, that's not that bad. Okay. I've never come across that before, but figured you would. That's why it's fun sitting next to a guy like him. He's already done all this fun stuff.
It is fun.
It is, right? I bet it is.
It is, especially when you see it working.
I mean, yeah.
I mean, CRRT, the only thing wrong, you know what's wrong with CRRT?
What?
I say this all the time as a joke. Probably people watching may know. The problem with CRRT, what does CRRT stand for?
Continuous renal replacement therapy.
That's what's wrong with it, the name.
The name, okay.
Because everybody thinks it's nephrology's domain.
Right.
And it isn't.
Right.
It's used to correct fluid balance. It's used to correct acid-base balance.
Correct.
It's used to correct, evil humor removal. It's used for a lot of things besides electrolyte adjustments.
I think
which every intensive care medicine doctor or cardiac surgeon does.
I think it gets that misnomer because
Of the name.
Of the name, and because of like dialysis clinics and stuff like that.
They don't have CRT in dialysis.
No, they don't. But that's what people think is what I'm getting at. That's what they think it is.
I wish they.
They
had
don't
called
realize
it.
that it's not dialysis.
The biggest mistake the companies made in building those machines was basically building them and marketing them to nephrology.
Yeah.
And once that was the pathway they took, it ruined the modality.
Right.
Because nephrologists are probably the smartest people on earth. But
Yeah, that's one of the hardest subjects.
there it is.
The renal
But
is full.
they have such a skewed view. They only understand dialysis in the intermittent world, and they're having a hard time bringing the continuous nature of it and how it works convectively versus diffusively and all these things. They really have a hard time understanding it. And they run the prescriptions instead of taking advantage of the convective clearance. They run everybody on CVVHD. So all you're doing is continuous dialysis. You
right.
never have any. So this is the problem with everything we do, every single thing we do. If we don't do it right, then it doesn't work. That
Right.
doesn't mean it failed.
Right.
It means we didn't use it right.
Right.
That's the problem.
That's why I like perfusion. We use everything we have we will find like 10 different ways to use the one
Yes,
thing we have.
That's right.
You know?
That one roll of gorilla
That
tape.
one, yeah.
Put the whole pump together.
Exactly. I mean, that's my favorite part about perfusion is we're given this and we're asked to do this. And so we got to figure out how to make this work in 19 different ways to get the big task done, you know?
Yes. Yeah, it's great.
I mean, that's my favorite part and that's, perfusion, man. You guys. MacGyvering. That's what we do.
We're all MacGyvers.
We're all MacGyvers. All right. So monitoring techniques. There's some ones in there, this is kind of where fun gets meets like tech meets physiology, stuff like that. There's PICCO, LIDCO, those kind of check the cardiac output, extravascular lung volume, stroke
You know what
volume.
LIDCO stands for?
I have no idea what they stand for. I just
can-
know what it is.
Well, I know what LIDCO stands
You know what LIDCO is?
It's
I just know what it is. I just don't know.
lithium dilution cardiac output.
See, that's
And
nice.
so they put a catheter in the wrist
Yeah.
and you disconnect it from the monitoring line
Mm-hmm.
and you connect it to a little pump.
Mm-hmm. Mm-hmm.
And the pump then flows into a reader.
Right.
And then you give a dose of lithium
Right.
IV
Mm-hmm.
and you turn on the pump, and the pump is pulling
it, yeah.
blood out of the radial past the sensor. And when it sees the lithium and then watches the lithium clear, it's able to determine
your cardiac
the
output.
cardiac output from that particular waveform. So that's how a lithium dilution cardiac output works.
Yeah, I never knew it. I just know you can tell the cardiac output and the
I'm
stroke
assuming
volume and things
I'm
like
assuming
that.
the pico is just
It's
a
probably
different
a different.
substance.
Yeah, it's probably just a different thing.
Yes.
I've seen a LIDCO. I've never seen a pico.
Yeah.
I just
Well,
know that
the-
these are like they're new. They're like pico's new. I know that.
Yeah,
Yeah,
but
it's
the
very
LIDCO,
new.
I've used it, and it's a great system. It was very useful, and was really neat about it is that you could, in fact, calibrate it. So it had a right because you do the lithium dilution curve.
Yeah.
So it's not quite like the random number generator on the Edwards
Right.
device that you don't calibrate.
Right.
But I think the Edwards device is pretty good. I mean, it is. It's actually it's endured more so than the LIDCO has. But the LIDCO had that one advantage. But of course, none of those technologies are good if you have a balloon pump or you're on ECMO or
Exactly.
anything like that.
Exactly.
They're no longer of
Right.
any value.
Yeah.
But they're really good with an intubated patient to measure in a closed chest to measure your intrathoracic volume.
Oh, okay.
Because you look for pulse pressure and systolic pressure variability with ventilation.
Right.
And the greater amount of that you see, the more volume, the more your volume need is.
Okay. Yeah.
Right.
Cool. See, I'm glad I have you here because I kind of know what they
It's
are.
a really
I just-
neat
I know-
device.
I've seen a LIDCO, never, I didn't know how
It's
it
like the
worked. I
flow
just
tra-
knew it
it's
worked.
like the flow track.
Yeah, okay.
That's the Edwards
That's
one.
that's
but you don't
that's
cal-
the Edwards one, right? The one
Edwards
that you don't have to calibrate, right?
Right.
Yeah.
But it has an SVO2 monitor on
Ah.
it because you put a swan in it.
Okay.
So the LIDCO is designed to not have to put a swan in.
Right. You can do it straight from the radial instead.
Correct.
Right.
Right. But the flow track does depend on to get all the use out of it.
Right.
Depends on
the
you need a
swan. So,
yeah, for
okay.
SVO2 monitoring.
So cool. So then another thing that they got, some of the newer age stuff, bioimpedance, which can estimate your total body water and volume distribution. They tend to use those like a dialysis clinic, stuff like that. Still, they're not even going to rely on that. Dialysis clinics are funny places. They have all these fancy tools, but then they'll still go off dry weight, current weight, stuff like that. The way they actually guesstimate on how much volume they need to pull off, it's very rudimentary. There's no fanciness in it. I spent about 4 months working at a dialysis clinic. You would think that they would have some kind of ingenious way to figure out how much volume they need to put off. It's not. There's no sound science in that. The other one is like point of care ultrasound, POCUS. That's like the kind that they'll roll next to you, your bedside one. It has
Hocus
IVC.
pocus.
Hocus pocus. The IVC variability. That's the one I was talking about a second ago, the one that makes some B lines. I think I do have a slide in here with it. Oh, it's the next slide. Okay, good. Yeah, with the B lines. I don't know. I was always intrigued by those when I first was told about it because I find it hard to see stuff on a ultrasound. I always have. I've never been good at them. It's just a limitation in my own personal practice. But I can see those because they're pretty evident. So they always stood out to me. So again, no tools are perfect, but if you use them together, maybe they can tell you somewhat of a story, and you as perfusionists, you're kind of uniquely positioned to read that whole story during bypass, and communicate it real time to anesthesia, surgeon, whoever you need to communicate it to. So yeah, I think next slide is, yeah, there they are. Okay. Again, this is ultrasound, the lung, looking for volume. If you see the B lines, again, that's here, that's this little sunburst line right here, right there. Those are your B lines. Again, this is the only thing in my life I've ever been able to see in an ultrasound. So I found it hilarious when I was doing my research that B lines came up in this, so I had to put a picture in there. I'm a very simple man with very simple needs, but that's the whole rationale for this slide. That's all I'm going to say about this slide. Just know that if you see a lot of them in the lungs, it means pulmonary edema. This one, you see a couple of them. So this patient's got pulmonary edema. He's got one here, you got one here, even got one off to the side here that if they moved the probe around, you would see it. So I'm not going to talk too much about the B lines. Again, that was just a nostalgic thing for me to include that. Another thing is IVC assessment. IVC being the inferior vena cava. It tells you a lot. If it's collapsed, it tells you a lot. If it's gorging and neck's bulging, it tells you a lot. I mean, all of the cavas will tell you a story. Even the SVC. Sorry, when I said neck, I was talking about the SVC. That one, if it's bulging, it tells you a story. The IVC tells you a story. Any volume in your body will return to the heart eventually, and when it does, it will make these vessels either smaller or bigger. It's either loss of volume, it'll get smaller and collapse, or it'll increase, But the funny thing is that you have to understand something about the IBC is that it collapses anyway with inspiration. So a little bit. So if it's collapsing a lot with inspiration, it probably means you're hypovolemic. If it's descending and not collapsing, you're thinking okay, volume overload. Like if you're taking inspiratory breaths and your IVC is not collapsing a little bit, it should collapse a little bit. That means you're probably volume overloaded, high CVP, stuff like that. It'll give away the story. Just remember this much though: mechanical ventilation. If you're in the ICU, you got a patient on ECMO, it changes everything. Okay, especially this. It's not going to respond the same. So just keep that in mind. The mechanical ventilation will change the dynamics of this. Obesity, elevated intra-abdominal pressure, they can kind of make readings tricky. But still, IVC assessment is still a powerful tool, especially when you use it with ECMO and a little bit of your common sense. You don't need a pack to assess the volume. You just need a probe with a good eye, and you can figure it out. So again, here's just a summary of those clinical tools that I was talking about, CVP, easy but misleading on your own. SVV, PPV, those are great for ventilated patients. The PLR test, it's a safe trial, like bolus used with the legs, that's the one where you lift up the legs. Again, they do it, Obviously, if you got an ECMO patient, be real careful trying to lift up legs in the ICU, especially if he's cannulated femorally. Don't go lift the non-cannulated leg. But this is, just throwing it out there as a thing that can happen. And again, you might see anesthesiologists, especially after the surgeon's out of the room and they've already broke sterility. They'll come do it. Obviously,
do it ourselves. Do it ourselves.
Yeah, we do it ourselves too.
You
right?
could do the passive leg lift, or you can just put them in Trendelenburg.
Yeah. Trendelenburg is another one. I was about to bring that up
then
next.
You don't have to worry about bending the leg.
Yeah, that's the number one way to do it while they're doing the surgery, and they'll do it. We go Trendelenburg multiple times during an actual cardiac procedure, and you can use those Trendelenburg positions as, markers at where you are in a case.
Well, I use reverse Trendelenburg to get volume into the patient.
Yep, and that's good too, especially because to get volume into the patient nowadays, especially these younger anesthesiologists, they love to give dilators. You know what I mean? And you don't need to.
They give
like
cardine,
you said,
they give a big slug of cardine.
Yeah, they'll give big old cardine doses. They'll really dilate them out, and then they'll be like, I'm making room for you. That's the key to I'm about to give a dilator.
Yes, right.
That's the lingo.
Right.
Or you could just do like Joe said. You put the head up, feet down, boom, you got some room.
A lot. A lot
of room. And you don't need to worry about, giving a dilator, which you don't really want to do, coming off pump. And, you don't want to mess with the hemodynamics because the patient's already in such a fragile state, and now here you are dilating out all the vessels and changing up the hemodynamic game when a time where you don't need to be playing around too much, So, yeah, echo, again, kind of the gold standard for volume and function. They've done all the time. In the ICU, it's done all the time. In the OR, it's done all the time. We just do it all the time. IVC, ultra lung sound, Lightco, Pico, all those other ones that I briefly talked about earlier. So capillary leakage in cardiac surgery, that's the thing too. Obviously, you'll see this all the time post-cardiopulmonary bypass. The body's inflamed, endothelium's porous. Sometimes they'll take off, you'll see them break sterility. They'll take off all the covers, and you'll just see the feet. They're all fat and edematous. Edematous? How do you edematous? Edematous. I just know how to spell it.
You just know the Indian word?
I was about to say, if I say it, then I'm going to sound like the Indian guy. I was taught by an Indian teacher and then went to India, Joe.
Exactly.
So many of my words, I was like, I'm not going to say it. Not on camera. I'm going to let Joe say it. So again, that's all due to capillary leakage. I'm going to try to move through here. I only
Which
have
is fairly rare.
It's rare.
True capillary leak syndrome.
Yeah. But it does happen, though. I've seen it,
Severe inflammatory response syndrome. Severe SIRS, absolutely.
Yeah.
But don't think for that. In those cases, you definitely don't want to give albumin.
No, because it'll just leak through.
It just makes matters even worse.
Okay,
and that's what they will argue a lot of times. So the patient's capillary leak. No, they're edematous for different. That's not capillary leak syndrome is dramatic.
Right.
You are really now, increased permeability is one thing.
Right.
True capillary leak is another thing altogether. And you are in some bad
that means
trouble.
your inflammation is really bad.
It's a good chance you ain't coming out of this one.
Yeah. Oh, yeah.
Once you get to that point.
Yeah, it's true. I mean, and that's...
When you lose your basement membrane integrity, you're done.
That's why we try to moderate all these cytokines and all this, why all the biocoatings.
That's
and
why
all
you should be ultrafiltrating on bypass.
Look at that, because
we'll talk about
it'll
that.
take it out.
We'll discuss that.
There you go. So let's see. Let me go on to a couple. I want to finish, but I don't want to beat up around some of these slides towards the end there. Oh yeah, let's go to post-op fluid goals. This is a good one. So yeah, in the post-operative world, fluids, they walk a tightrope. A little too much, you got hypoperfusion, AKI, hypotension. A little too much, you risk everything else, So again, in the post-op goals, essentially, we want to maintain perfusion. You want to avoid overload. That you definitely don't want to do. Tailor the fluid response, not a habit. I tell you guys this because that patient might be on ECMO. Maybe he didn't come off pump. Maybe we had to put him on ECMO. So you might be in the ICU. You may have to deal with all this stuff. Usually, we don't deal with this stuff, but it may. Use your lactate. Use the mental status. Changes, imaging, anything. Echo here is your ally. They're like I said earlier. Don't solely rely on CVP. Instead. Talk, to your intensivist. Talk to the cardiologist, the surgeons, what's going on, especially if the patient's on ECMO, because that volume, again, you're still playing a big deal. And not number one, you need it, but at the same time, you don't want to overload. But you need volume to flow with ECMO, so it's volume's a good talk to have if the patient's on ECMO. It's a talk you should have, So let's see. Alrighty. So the conclusion. So let's wrap it up, okay? So again, like I said earlier, treat fluid like a drug. You know, it needs a reason, a dose, a stop time. You don't just give. And you sure as hell don't give without thinking. Okay, that's one of the worst things you can do. You would never just give any medication without thinking. And if you are, then maybe you shouldn't be doing what you're doing. You know, more is not always better. Smarter is always better. You know, use physiology. Don't just reflex, do stuff. You know, look at your patient. Don't look at the monitor. Monitors will get you in trouble. You know, you're not a passive participant, is what I'm getting at. Talk to everybody. Know what you're gonna do. Talk to your anesthesiologist if you're in the OR. Don't talk to the surgeon. They don't want to hear about fluids. That'll be you're not gonna. That surgeon will not like you if you start bothering him during his surgery about fluids. But talk to your anesthesiologist. If you're in the OR, if you're in the ICU, you could talk to surgeons if they come back. You know, that's a different setting. You can talk to your intensivist, you know, talk to the cardiologist, whatever. But just, you know, stay in the loop. And, you know, that should be it for me. That's my image references. I don't care about those. And there you go. So stay curious, stay critical, stay compassionate, and stay caffeinated. And there is my email, Samir Patel at HETUS. You guys can contact the main PerfWeb web.
Either
with
way,
any
yeah.
either one is
Contact,
fine.
Info.
They'll both reach
you,
me. Yeah.
You'll get whatever emails come.
Yeah, so they'll reach me, bottom line, and this is a hard topic, so don't hesitate.
Cool. Okay.
Yep.
Okay. All right. Very good. I can't wait till tomorrow.
Yeah, that's gonna be fun.
Yeah, we got to try to drag a couple of other people in on this.
How are we gonna?
I'll find them. Trust me.
Okay.
Listen, I can find somebody to argue with me all the time. It's easy. All I have to do
So
is
what you're saying? Why do I find that not hard to believe?
you know, it's true. Believe me.
You're
Okay.
polarizing, you're saying?
Yeah, controversial.
Controversial.
I like to be controversial.
Sure.
I enjoy it.
Do you have your little, I think you want to do a podium or what?
Yeah, I'm going to do podium.
Okay.
Give me something to do. Okay.
I'm going to go to the restroom.
Please, go ahead.
Oh, wow.
Why don't we do that? Why don't we do that? Can we take a 5-minute break? I think 5 is enough. Yeah, 5 minutes. We're going to take a 5-minute break, and I'll be back. off. Yeah, we're back. Yay.
Yay.
Okay, cool. All right.
Look at
Ultrafiltration during CPB. Why is this so controversial? I don't know.
It was a few studies, Joe, and it
So-
made it controversial.
So what is it? What is ultrafiltration? It is a process, and I wrote this myself, by which plasma water is removed by passing blood through microporous hollow fibers, and that have obviously pore size that is consistent with what it is you want to remove. In the case of a standard hemoconcentrator, not a high flux hemoconcentrator, just standard like we normally use every day, is 50,000 Daltons. So 50 kD is the pore size cutoff. Now that doesn't mean that everything that is less than 50,000 Daltons or 50 kD is going to go across. It just really depends on a variety of things. If you're trying to do diffusive clearance, it's not going to work very well. If you're trying to do convective clearance, then you can get, out stuff pretty big, much bigger than you can diffusively, that's for sure. Okay, hollow fibers, the pressure gradient drives the plasma water through the pores to an effluent container. This is standard ultrafiltration. So the pressure has to be higher on the blood side of the fibers, and the pressure pushes the water out through the pores and into the effluent container. So by nature, this is a convective model. The pore size and pressure gradient will influence the size of the molecules that pass through the hollow fibers. The effluent will be isotonic, and of course, we just got a whole big lesson on that. So we know what isotonic means, and therefore will not affect the plasma concentrations of solutes. And anything not removed will increase in concentration vis-a-vis red blood cells, plasma proteins, and this will, of course, result in the COP increasing, and this will also increase your PRR, which is your plasma refill rate. It's very important for us to understand conceptually that as blood reaches the capillary, you will have water leave the blood and fill the interstitium, and then that water will come back in the post-capillary area, and that's what your plasma refill rate is. But not all of it comes back, and some of it makes its way back, and as Dr. Patel had told you earlier, that all volume eventually makes it back to the heart, right? So
Always.
in this particular case, it's going to come back through the lymph system, but it will eventually get there, just much slower, right? Okay. So, and I'm going to be a little controversial today, okay? So I'm just going to tell you in advance. I know I said it already, but I wasn't joking. There are those that believe that ultrafiltration causes renal failure. And I believe these people are ignorant and have decided that, and that it is going to be their hill to die on. And they're just fundamentally wrong. AMSECT and the people like Al Stammers, Kurti Patel, Linda Mongero, and I'll show you some of their research, if you want to call it that, describes this in a way that has led many people to believe that ultrafiltration is somehow bad. And it's just fundamentally wrong and seriously bothers me and seriously concerns me, because it makes my ability to do my job the way I believe is best. And I have my own two eyes and my own personal experience to know how these patients in cases that I do are doing postoperatively. So I'm happy to compare my outcomes to somebody else's, but I think that the way this research is being done, it's too much in a vacuum. You're comparing one variable when you're not controlling for 10 or more variables that will have a direct impact on kidney survival. And if you don't control for those things, then you have completely invalidated your study of this or that. Doesn't make sense. So Samir went through this with you. We've all seen this before. Basically, your body weight times 0.6 is going to give you essentially your total body water. So we are fluid. We are 60% liquid, basically. And you see here, total for a 70-kilo person is going to be about 42 liters. Now, that's divided into the two compartments that Samir talked about, intracellular and extracellular. Now, the only one of those two that can be further divided is the extracellular fluid, the extracellular fluid, and that can be divided into the plasma. The plasma and the capillary wall. So right here. Okay? So your extracellular fluid is all of this. So your plasma volume and your capillary wall, such a small amount, is this 3.5. This whole thing here is 14 liters, right? Extracellular. There you go. All right. It's important to understand. This is also critically important, the venous capacitance system. Assessment of intravascular volume status and responsiveness. I'm going to read this in the critically ill patient. Using the right word or phrase to describe a specific pathologic process or patient diagnosis and or status is important, not only within the ICU team, but also when we communicate with external consultants. This is not just a question of semantics. For example, it's not uncommon to see clinicians examining an edematous patient saying the patient has fluid overload or hypervolemia, or both, and proposing fluid restriction and or diuretics as the logical strategy, where often during the acute phase, especially of resuscitation from circulatory shock, this approach may be grossly inappropriate. And I'll tell you what I mean by that. The most fluid overloaded patient that I've ever had any involvement in, and they lived, was 28 liters fluid positive.
Wow.
28.
That's a lot of fluid.
28.
That's a lot.
Not just by I and O's guessing, by weight. 28 liters fluid overload. This person did not look human anymore. Mm-hmm. But she did survive.
Wow, great.
She did survive. Believe it or not, survive.
Amazing.
She lost her leg, but she survived. She had an infected leg. She had a gangrenous leg.
Yeah.
And they kept whittling it away, but they wouldn't just go above the knee. They kept trying to preserve the knee, but eventually they just had to come up above the knee and take it off.
And that caused all the capillary leakage and all the
stuff
that we were talking about earlier.
This was bad. This was bad. I couldn't believe she survived. So approximately 70% of the total blood volume lies within the venous system. That is your total blood volume, meaning your intravascular. We're saying blood. When I say blood volume, there's only one place blood's going to exist.
In your vasculature.
And that's intravascular, right?
Right.
Red blood cells. Unless you're bruised, you have something else. You exudate. You have red cells in your tissue. You obviously get bruising, right? and about 10% is in the capillaries. This total blood volume can be estimated as 70 to 80 mLs per kilo. And when the heart is stopped and blood volume distributes itself from the poorly compliant high-pressure arteries to the highly compliant low-pressure veins, an equilibrium pressure is achieved known as the mean systemic filling pressure. Now, this is it's typically between 7 and 10, but it's very hard to actually measure this because you have to let the heart stop. So that's kind of hard to really do, but this is what they have come up with. But what is the takeaway message from this? I won't go through it all. Is, you know, because you have stressed and unstressed volume. There's a lot of factors here that play a role in this, but I want to keep it limited to my point, which is the venous capacitance system can hold an enormous amount of volume, an enormous amount, more so than you ever thought it could. And if the heart is okay, it'll manage it. Takes a lot to tip somebody over the edge who has a normal heart and put them into actual hypervolemic heart failure. I'm about to tell you something else about that 28-liter fluid overloaded patient. She was seriously intravascularly volume depleted.
I was saying that earlier.
Depleted.
I actually mentioned that, where it can look like it's hypervolemia, but your body will they're actually hypovolemic.
And this was their point.
Right.
This patient does not need fluid restriction.
No, yeah.
And this patient definitely does not need diuretics.
Right.
Because their blood pressure was for crap because they had no volume in their circulating.
Right.
It was all leaked out.
Yeah, it's not in the intravascular space where we need it.
And everything we gave went out with it.
Right.
So, assessment of intravascular volume status. Here we have optimum fluid balance with the balanced scales. Volume depletion results in hypotension, shock, organ hypoperfusion, and AKI. And this is very important for you to understand. Volume overload, on the other hand, results in impaired oxygenation. And I'll explain to you why that is, but it's fairly intuitive. Edema, hypertension, and organ congestion, which can create problems with perfusing that organ, right? Mm-hmm. I wish is there any way we can move that a little bit? Can I move this just a little? So, because I can't see Samir. It's like I'm just looking at a blank screen that has nothing. Yeah, just the TV.
I can also scoot over a little bit, Joe.
Yeah, just the TV. That's good. That's all you had to do. That's it.
You're good? Okay.
Yeah, it's just it's in the shot, but
yeah,
it's in the shot, but you might want to pull it back just a little bit. Yeah, there you go. That's perfect. That's perfect for now. Yeah, that at least I could see them.
Yeah.
It's just it was uncomfortable. I'm sorry. There you go. That's not bad. That'll work. You got the door, but it's not too bad. A little more. Keep going. Right there. Now I'm in the right spot. That's perfect. Thank you. Okay, so inadequate versus overaggressive fluid therapies. Now, let's get to the meat of this matter if you can. Most people think there are a lot of bad people running around the world. There aren't a lot of bad people. There are a lot of bad ideas.
Yep.
And bad ideas are worse than bad people because bad ideas are contagious. Bad ideas get good people to do horrible things.
This is
okay.
Well said.
Somewhere and somehow there is a group of people using this, what I consider to be twisted logic, suggesting that ultrafiltration on CPB causes AKI. So let's try, if we can, to follow the logic. Because I don't want to say they're bad people. Mm-hmm. But man, they got some bad ideas. And they're publishing this stuff. And we're going to get into it a little bit.
Right.
And it's really concerning to me. Okay, you're new in this industry. You're not new in medicine.
No.
I get that.
Right.
But you've seen this before in other disciplines. And we're seeing it in ours too.
Right.
Where you publish something and some of this stuff is really weak. It's
I mean,
not good science.
policies get rewritten because of
not-
something that's published, right? Like
Correct.
entire policies.
And this is what concerns me.
Yeah.
Okay? Because I've got an axe to grind. I'm just going to tell you right now, studio audience knows me pretty well. I really have an axe to grind with AMSECT and all of their micro certifications and their statements like this that say that ultrafiltration is, causing harm based on their data, which I think is terrible. But it is what it is, right? And I'm going to push back, and I think that I have a responsibility to push back. So, you guys out there, you know what? I'll give you the invitation. Curdy, Al, what's the other person's name? Linda. Any one of you three, all three of you. You want? You can call in. You don't have to come here. You're welcome to come here, though. I'll even feed you. Call in. You know what? Reach out to me. We're extending an invitation to you to debate the topic with me. You can decide. So here is the article that I am referring to.
Yeah.
And
this was the one.
I'm going to just go through the limitations, the conclusions, and then I'm going to do a little bit of other critiquing if I can. The present study has limitations. The study was conducted using a national registry of data collected in a prospective but non-randomized manner. Now, that registry of data is basically specialty care's internal data that they collect from all of the cases that they do. Registry data do not permit the investigation of certain factors that may be pertinent in determining effects not found with limited variable analysis. Then you shouldn't be making any conclusions. How's that? Although database analysis is useful for identifying trends, the absence of physiological determinants of AKI precludes a definitive outcome of UF on renal function. I'm not going to bother reading the rest. Conclusions. The use of registry data from more than 200 hospitals across America, that sounds so impressive, guys, has shown that use of ZBuff, and are we talking ZBuff? Are we talking ultrafiltration? I don't even think you guys even differentiate well either of these techniques. And ZBuff is zero balance. So I don't understand that, but I guess, and did you use a bicarb-based fluid? I'm sorry, do you know what that is, or did you use normal saline 0.9 with bicarb added to it? So how did you do it? I mean, you talk about variables. Where's the consistency? Not one of your programs did it the same way. So how can you possibly say that 200 hospitals, you can infer anything from that? Well, I can tell you how. You can't. The conclusion. That ZBuff is associated with reduced intraoperative urine output in cardiac surgical patients that supports our previous findings, which I didn't even put in here, when CUF, continuous ultrafiltration, was examined. Although the reductions in urine output were modest, they were related to the total volume of exchange fluid and may affect renal injury when large volumes are used, especially in patients sensitive to acute injury. Further research is necessary to confirm these findings in prospective evaluations. And they acknowledge their sincere gratitude to the Perfusion Associates of Specialty Care who participate daily in the quality improvement process that is dedicated to improving patient outcomes. So let me ask you guys this, okay? Since you published it, is this a study or is this an advertisement for your company? Moving on, if I may. That's what I think of your study, right there. Okay? I think it's wrong what you're doing. Fundamentally wrong. In this particular study, a little more, I think, valid. The study enrolled patients with their ages, their demographics are there. You can read that yourself. The results showed a significant association between ultrafiltration volume and the risk of developing AKI, with higher ultrafiltration volumes associated with a higher risk of AKI. In the multivariate analysis, the other predictors of AKI included age, lowest mean arterial pressure, red blood cell transfusions during CPB. Conclusion, the predictors of postoperative AKI and coronary artery bypass patients were the volume of ultrafiltration, age, MAP, and blood transfusions during CPB. So again, it isn't a this or that. There's a lot of factors that play a role in this. And I'm going to tell you all something else. When I do the procedures and I'm proud of myself for this. I developed a procedure. I don't even know if you even know about it. So in the past, when we would do minimally invasive mitral valves through a right anterior incision that the surgeon would do, and we would cannulate femorally, you would have an all-day affair of putting in port access or heart port or whatever they call it now, right? The balloon occluding device, and you had to have 2 radial lines, and you had to put the cannula through the same port. It was a really small, or the balloon went through the same port as the cannula did. And so you basically have this real high line pressures, 300, 400. It's crazy to do. Have you ever done one?
No.
You've never done a port access case? Oh my God, look it up. It's miserable.
I've seen them.
It's horrible.
I didn't pump it though.
And it's really interesting because one of the
standby on that,
just look it up. Port access, I think it's called. Edwards makes it. But the contraindications for it, interesting, or one of the contraindications, is any AI. You can't have AI, right? Because the balloon occludes at the sinotubular junction, and then the cardioplegia is infused.
Right.
And if you're infusing the pleats too fast, the balloon might migrate north and occlude the dominant. So that's why you have to have 2 radial lines. You have to compare them all the time
to make sure you're not
occluding
the dominant.
if you're right, and if you're venting too hard through that same line, you can pull the balloon forward towards the valve. So then you have to make those adjustments. So it's a very challenging thing to do. So I decided to convince a surgeon that what we're going to do is not use any of that. Patient had only minimal AI, and I'm going to give the patient 400 milliequivalents of potassium systemically. Get on pump, cool them, give it potassium, stop the heart.
So not please, just potassium.
Right. Don't touch the aorta.
Yeah.
You don't ever touch the aorta at all.
Yeah, so you don't need to worry about
and I CVVH or I Z-buff with a bicarb-based solution.
Take the potassium back off.
I've done probably personally 60 of these cases, probably about 60. My colleagues that I've taught how to do it have each done probably 20 or 30 on their own. So we're probably talking about, I don't know, couple of 100 cases, maybe 300 cases altogether. Do you know how many of them got renal failure? None. Do you know how much I ultrafiltrate how much I Z-buff during those procedures?
A lot. That's
25 liters.
Yeah, I was about to. That's a lot of potassium.
25 liters. 25 liters.
And that makes sense because
and
1 liter is not going to bring down almost nothing.
People pee like racehorses. I did a heart today, and it was really interesting because the surgeon was like, new surgeon, never worked with him before, brand new hospital, really cool. He says, I really like to run my mean pressures higher, man. I don't like it under 80. Normal is 94, 95, right? Mean. So I want the mean 80 to 90 would be great. Dude, we made 600 cc's of urine in an hour. And I ultrafiltrated 1800.
God, that's a lot of urine for an hour, too.
Right. Right. That patient's still peeing. So I have 2 eyes. I can see. I don't see what they're talking about.
Right.
I cannot ultrafiltrate at all, and the patient doesn't make any urine because the pressure's too low. They're not going to make any urine. We're running our pressures so low compared to what is physiologic. So you're taking away the pulse. There's no way a pump system can generate a physiologic pulse. So I think trying to pulse is a very bad idea. It carries with it incredible risk for minimal gain, if any. I don't even think there's any gain. I don't think it's beneficial at all. So, because look at the waveform, not a pulse, right?
Not in the arterials. Yeah, you're
No,
right.
it's not a pulse.
And by the time you get to the afferent, it's like
There's nothing.
There's
right.
nothing.
This is
Yeah.
pointless.
Yeah.
Right. The upstroke is too slow, and,
Yeah.
and you're just beating the blood up. I think it's a
Right.
really bad idea. But
Right.
anyway, moving on from there. So those are the predictors. So let's go over this and do this in a way that I think will be fun. Okay? So here we have our body water compartments, and you just saw that. Okay? Let's see. How do I make a, oh, there. Oh, okay. That's how it works. Okay, so we're going to say that this patient over here has this is their volume. Okay, I'm just going to leave it as it is. So they have 3.5 liters of plasma volume. So I'm going to give them some solids in there because you're going to have platelets and you're going to have red blood cells and white blood cells, and these are solids, right? So 70 kilos, 70 cc's per kilo, 4. Now we're going to say 5 liters. So you have 1.5 liters of solids in your blood volume. So 5 liters total blood volume. Blood volume. Okay? Here you have your hemoconcentrator, and your hemoconcentrator is telling you a little bit about diffusive versus convective clearance. So that can give you a little bit of an idea of what is the difference between dialysis and ultrafiltration really is. And you go on bypass with this patient, and you have 2 liters in your tank. Okay? 2 liters. Over here, in your patient, your heart is now empty. It has 0 volume. At this point in time, what is going to happen physiologically? Dr. Samir? What happens? What is the heart going to do? What is the heart going to say to the kidneys at the moment we go on bypass and it is now collapsed?
It's going to tell you to retain water.
Got to do something because this isn't right.
Right.
You have no tension on your atria.
Right.
Your atrial natriuretic peptides are no longer being stimulated.
Yeah.
And your
literally gonna be
kidneys
zero.
are going to say, whoa,
we
are in
retain
hemorrhagic shock here. So they're going to hold water. That is a big reason why you see diminished urine output on bypass. The stimulus for it is taken away. Now, over time, because you're flowing, but the second reason is, listen, convince your surgeons, run a higher pressure, you'll have higher urine outputs on bypass, I guarantee you.
Right.
This is on low power mode. This thing's going to die. It's going to die. I'm sorry. Okay, so I'll keep moving on.
There's a charger over here, guys.
So in this particular scenario, this patient has 16.5 liters of volume in their interstitial space. In their interstitial space. Okay? So, and our albumin level, I'm going to say in this particular case, after we went on bypass, we hemodiluted, I'm going to say it's 3.4. Your COP is, I don't know, give me a number. What do you think? Should be what, 25?
Should be, that's normal.
I'm
yeah.
going to make
it's
it.
going to be lower.
I'm going to make it 18.
Yeah.
You know, we never measure
With
it.
a 3.4, it's going to be lower.
Yeah, why don't you measure? Yeah, you should. Oh, shit. Well, that's not good. How do you delete only one thing?
I was doing the same thing, Joe.
Oh. Well, I can't do that.
David over there
Just do this.
did not teach me properly. I
He
had to
didn't.
learn
He
on the
didn't.
I had to
Okay.
learn on the fly.
2,000, 5 liters total, and in the interstitium. And then you have the 14 liters in the interstitium.
Right.
Okay? And albumin
You said
was
it was
3.4.
3.4, correct.
Okay.
And we called the colloid
Yeah.
oncotic what, like 18,
Now, let's
19?
just hypothesize here something. You're probably thinking to yourself, well, you know, here, get rid of that. Oh, it's putting it on there. They probably gave a lot of volume. If you notice, your hematocrit from the night before and your hematocrit now in the operating room is probably a lot lower. So, and that was that talk that I told you about the other day, that girl, Emily Foreman.
Yeah.
See, this is what they
Right.
dealt with and how they solved their problem. Was they treat the patient much more holistically, if you will,
Yeah.
versus us, where we just pour volume in them. Anesthesia just pours the volume in. So you started off with a crit of 37 on the chart the day before,
Now
but
you're like at
now
29.
it's 30. Well, that's
Yeah.
what it was today.
Yeah. Yeah,
30.
that sounds about right.
So I know this interstitial volume is now more than likely, let's just say it went up to 18 liters, 4 liters. That's
Yeah.
nothing.
Yeah, that's
you can
nothing.
hide 4 liters in your interstitium easily, and I'll show you some really interesting pictures about that. So now I'm going to do something. I'm going to just ultrafiltrate off 1 liter because I don't need 2 liters in my tank. So I'm going to take this right here, and I'm going to, let's see. This will work. I know how to do that. I'm going to change this to 1 liter. 1 liter. I'm going to put 1 liter here. When I do that, 2 things are going to happen. Several things will happen, but 2 things in particular. Something's going to happen to this, and something's going to happen to your hematocrit. What do you think that might be? Yes, it's going to go up.
Obviously.
So let's take this to 3. Let's say 4. I'm going to give 25 grams of albumin on top of it. Let's just get this to 4. Your crit was 22. Now it's 24. Things are looking better. This will result in increasing what? You're right.
Your
Your
colloid
PRR, plasma refill rate.
Yes.
You take 1,000 off, you might have given 50 cc's with the albumin, maybe 100, but all of a sudden the volume in your tank after taking 1 liter off is back up to 2 liters. Well, where did that come from? Well, I'll tell you where it came from. It came from the interstitium. So now this is 17. Still more than it was. Weigh the patients. I'm telling you right now, weigh the patients. If you want to know what their actual weight,
We were
what their
talking
actual
about this.
volume, fluid volume is, weigh the patient. You'll know if because they're not going to gain muscle mass and they're not going to lose a whole lot of fat unless you're doing amputations during the operation or they pull out this big thymus or something. You know, maybe you'll lose an extra ounce or 2, but that's about it. Weighing the patients really makes a difference. So if I do this a couple of times, I can easily remove 3 liters from the interstitium not be by any stretch desiccated, and still have fully preserved intravascular volume. Because if your COP is normal,
then your PRP will
you will get back what you need to have the tank full.
Yeah.
Does that make sense?
Yeah, because your PRP will be normal, so it'll pull.
Precisely.
Yeah.
Precisely. Won't pull it all.
It won't pull it all.
Because it never pulls it all.
No, because it'll eventually
Does
become
anybody
equal.
know? Does anybody know what the overdose volume of albumin is?
I don't know.
There
that.
isn't one.
Okay, yeah, I've never heard of one.
Because there isn't one.
Okay, trick question.
When something has no overdose, when you can't overdose something, it can't be bad for you.
But it's expensive, Joe.
Yeah, I know. It's expensive. Right. It's expensive.
All $38 of it.
So this is what
Yeah, those are puffy eyelids I was talking
fluid
about.
overload looks like. And this is mild,
I had
very
mentioned
mild. Her
puffy
tongue
eyelids.
is not yet on her chest,
Right.
but it's coming. Okay? This is a little bit more of a, I think, an illustrative picture from my perspective.
Yeah, that's...
If you look at this heart, you're probably thinking to yourself,
that is a dilator.
this heart looks really just stuffed, right? But that's not all you see. Really look at it. And you can see the glistening, the kind of wetness. And what you have here is a severely edematous myocardium. Much in the same way, that picture, which you're looking at right here, or when you see this right here, it is not simply a displeasing visual finding. That is happening in all of your body, inside. Your heart edematous, your kidneys edematous, your gut edematous, which you talked about, your liver edematous, your lungs,
everything.
pulmonary edema,
Yeah, everything.
your brain, okay, that too. So you take that into consideration and you easily can understand why, and I don't have a lot of the studies on the computer because I'm not going to go through reams and reams and reams of study. I think we all understand that the best science out there says that drier patients in the critical care unit do better. Drier patients do better. Fluid overload is an independent indicator of mortality, much like hypoalbuminemia is.
Yep.
So we know that. We know that is a fact. Cardiac surgery patients, by nature of the operation, are critically ill for some period of time. Drier patients do better. Now, can you inflict deleterious effect with ultrafiltration? Of course you can. Can you overdo it? Sure, you can. You can desiccate a patient. You could give them all kinds of hypertonic fluids, pull fluid from their intravascular, intracellular, extracellular, extravascular space. You pull it off there and get it in and remove it. But that's going to obviously do a tremendous amount of harm. We're not talking about that. We're not comparing this to that. What we're doing is a much more moderated approach of not creating a hyperoncotic or hypertonic either solution, but rather making it normal. So you're not going to pull back out of the tissue any more than what would normally want to be back in the vasculature if your numbers are normal. So assessing the patient's fluid volume, going, okay, they gave the patient 2 liters overnight, they peed twice, a couple of hundred cc's, they're under anesthesia now, they're making a scant amount of urine, they're just little bits of urine, so everybody's worried about urine on bypass. Well, hell, there's no urine output before we went on pumps, so what's the difference? You know, why is it all of a sudden a bypass problem? Well, it was like that before because they're running the pressures too low. That's a different issue, right? But nevertheless, it's something to consider. But you look and you see 3 anesthesia bags gone, 2 in the trash can and 1 empty. You're fixing to give a whole bunch of prime. Fixing to, that's medical. And if you're using Del Nido, you're going to give a liter of that. Well, if you don't ultrafiltrate anything, where the hell do you think all that volume is going to go? And then it's kind of like these studies that compare transfusions and outcomes, where, okay, but are we transfusing, like, what are we transfusing for, right? I mean, you can't just put it all in just a vacuum. You can't just say because of this, that.
Yep.
Right?
That was my take-home message yesterday.
Right.
Like,
right. These are seriously important concepts.
Right.
But it is very important to understand that if you see this in the face, you're gonna see this in the heart. If you see that in the heart, you're gonna see that in the kidneys. You're gonna see it in the brain, heart, lungs,
gut,
liver, gut.
everywhere. You'll see it everywhere.
Everywhere.
Everywhere the blood
And
travels.
as you increase that tissue edema, we all understand this, you get perfusion deficits because the microcirculation is under too much pressure from the thickened, fluid-filled interstitium to be able to flow through. So it starts going around bridges, and you start losing areas of perfusion, or just can't, pressure's not high enough to drive it through. And the organ is dysfunctional with that edema on its own. Now it's also ischemic because it's being poorly perfused. So in my opinion, bottom line is if you do not use ultrafiltration on every case, you are doing your patient a terrible disservice. It should always be hooked up. It should always be used. It should always be available to be used unless you're Emily Foreman and you have a comprehensive approach towards fluid management in the operating room. And you have to have a patient population that is healthy enough otherwise to be able to do that with. We can't do it here. We get really bad patients with EFs of 20% is not unusual. Patients who have been in the hospital for several days, already on Impella, beaten up like crazy. And we get some really sick patients. So it's unfortunately not feasible, but in some patient populations, it is. If I didn't have ultrafiltration, I can tell you right now that I'm happy to compare all of my outcomes, and I ultrafiltrate a lot, to anybody else's who doesn't. And I'll put them. I'll put it up. Let's compare it. Here's mine. Show me yours. See what happens. Questions, comments, concerns?
Nope. I was hoping that you would segue after me. See, I figured you know.
Was that controversial enough?
Oh my Lord, have mercy. I think you could.
David?
I feel like I'm part of the controversy now.
Do I win the controversy award? Good. That pissed some people off?
Oh man.
Good.
You were
I'm glad I did,
names
because that was my goal today. That was my goal. You know, I have been doing this job now. I graduated from perfusion training in 1979. That's a long time ago.
Right.
And I have always been, and continue to be even more so, troubled by the likes of the AMSECs, the specialty care, Al Stammers, Kurti Patel, Linda Mangiero, band of people who have whatever agenda they have, and because they have this system, they can just force out totally crap science. And for what purpose? How does this benefit me? It doesn't. You want to know why I'm not a member of AMSECT? That's the reason. I don't want to be involved with people who really don't understand what clinical practice is like. And I don't think you do. Have a good day. We'll see you next tomorrow.
There's controversy. I'm not as controversial.
Think I like?
Yeah, Lord.
All right.
What are we doing?
No, I don't see anything.
Yeah, right there.
I don't, dude, I can't have, my computer's not open.
There's a comment?
Yeah, nobody was monitoring it. I asked what's his name to do it.
Magic?
Magic, but he doesn't. Nobody listens to me. Hello, Joe. Hello, PerfWeb team. Thank you all. Hofstra Perfusion students starting this fall, just wanted to say thank you for what you are doing. You've helped me prepare for my shadowing cases and find a love for this field.
Yay.
Well, Liam, welcome to Perfusion. Yeah. It is I will tell you right now, it's a full contact sport. And
especially if you're Joe.
It's a full, no, it's still, believe me.
He likes to swing.
Let me tell you, I'm going to tell you all something. I wouldn't be swinging like this if I hadn't spent a lot of years getting my ass kicked.
There you
it's
go.
just my turn to kick back now.
There you go.
Okay, that's about where I'm at. I'll tell you where I'm at. I'll just be completely transparent about it. I'm at a place now in my life and a place in my career and a place in my brain that it's like, you know what? This is it. This is what I'm going to say it the way I really think it. Not having to sugarcoat anything, because I'm not going to. I'm just done with that. I'm just going to tell you how I feel. And I feel very strongly about this. Again, I have done 25 liters of Z-Buff on a number of people.
I was flabbergasted when you
that
told me that.
No one, not one of them has, in fact, one of them, it's really strange. You ever give 400 milligrams of potassium to a renal failure patient?
Yeah, never.
End-stage renal disease?
Yeah, that's crazy talk.
I did this on them.
Yeah. And you had the surgeon's blessing. That's
Yes.
That's the crazy part.
That was the first one that I did.
That's nuts.
She was in renal failure.
I wouldn't do it, but that's crazy.
It worked.
It did.
Great. Just
That
don't
was
give
a-
the potassium real fast.
No.
It's a little
Yeah,
vasoactive.
yeah.
It makes
And
the pressure go up.
Literally burns
You have
the
to give it
vessels.
you give it an aliquots.
Yeah, it
you have
has
to be
to.
careful. You know.
You gave it central, like IVC?
Into the
central?
pump.
Okay, yeah, perfect. IVC then.
Yeah, right into the pump.
Yeah, it has to be in a large vessel.
Yeah.
You will burn the little
Yeah,
one.
but you just give aliquots of 40, 20 or 40. Wait a little bit.
So you gave 10 little bottles of 40?
No, I just had a big syringe.
Okay, yeah, you had the
drawn
big one.
up.
Yeah, okay, perfect. Oh, man, yeah.
Yeah.
Wow, 400 to a renal patient. That's nuts.
Yeah. I'll tell you what happens
So,
when you get it.
so if you didn't do your Z-Buff, there was no way that it's coming out.
Correct.
Like, it's
But
just in there
but
forever.
according to these datas,
Mm-hmm.
I should have put every one of them in renal failure. 25 liters of Z-Buff? Ain't nobody doing that.
I mean, it would take that much to work off 400 MEQ,
Yeah,
though.
it's
at
really
least.
amazing. It is amazing. And I have used it for so many different things. You know, we do CVVH.
What'd you use for your Z-Buff?
Bicarb-based fluid like Prismasol or
Okay.
Duasol or
Okay,
Next
yeah.
Stage has a version of it. There's
Yeah.
like various different fluids, but it's bicarb-based.
Yeah, sure, yeah.
And, you know, we have these
it's
CR...
not just saline with bicarb.
Correct.
Yeah.
No, it's normal. Everything is
Yeah,
normal.
everything's
It's got
normal.
Bicarb, it has sodium, potassium.
Yeah.
Everything is normal.
It's not
Sodium,
hypernatremic
potassium.
is what you're getting
There's
at,
zero
right?
K in it. So you can get 0K, 2K, 4K, whatever you want.
Yeah.
And
Well, the
if,
0K is going to work the best.
And
you know.
if what they're saying is correct, I didn't even think about this. This is another really important point. If what they're saying is correct, then CVVH or CRRT, which is continuous
Both are, yeah.
Z-Buff in the ICU 24/7, 3 liters every, couple of hours of Z-Buff, why are all those people not in renal failure? Why?
Controversy.
How does that make sense? Read up on CRRT.
Lord.
Spend your time reading up on it and see what it can do. How is that not going to cause renal failure? Because if that does, that has to. because that doesn't either. So I would just ask my colleagues, let's try to tighten it up a little bit. I think you guys that are, running these papers out and just pumping stuff out so you can talk great about your organization or whatever it is. You know what? That's not what this is about, man. This is about real patient care. Get focused back on what it's supposed to be. Thank you all. I love everybody, even those of you who I perhaps think you seem like you might be someone who is a detractor, but that's okay. I still love you too, and we will see you tomorrow for a nice, good fight. Come into the inferno.
Come into the inferno. All right. Have a good one, everybody.